Welcome to the start of the NIH Office of AIDS Research and National Institute of Mental Health's HIV and Intersectional Stigma Workshop. I am Paul Gaste, and I work in the NIH Office of AIDS Research. I'd like to thank everyone for being here today and would like to acknowledge the Office of AIDS Research and the National Institute of Mental Health leadership who have supported this workshop from its inception. I would also like to give huge credit and appreciation to my planning group colleagues, Dr. Greg Greenwood of the NIMH Division of AIDS Research and Ms. Amber Wilson of the NIH Office of AIDS Research, as well as to our behind-the-scenes event producer, the Bizzell Group. In this opening session, you will hear from distinguished members of NIH and Department of Health and Human Services leadership about the importance of HIV-related intersectional stigma, as well as key points of context and about the three-phase approach we will be taking over the course of this workshop. In the attempt to best address HIV-related intersectional stigma and discrimination, and to do justice to the importance of these topics, we invited and have assembled you here today as key experts and noted change agents. We appreciate and were impressed with the high level of interest and enthusiasm with which you accepted your invitations and committed to this effort. Thank you for that. Together, through the structure of this workshop, we will cover a lot of ground, and I have no doubt do groundbreaking work in the relatively short amount of time we have set for this. We appreciate you being here. Now, I will turn this over to Greg for some additional remarks and details about today and the workshop overall. Greg?
Great. So thank you very much, Dr. Paul Gates, and thank you, Ms. Amber Wilson. It's truly been a wonderful partnership to work with you on this meeting, and I'm grateful. I'm also grateful to the leadership of the NIH Office of AIDS Research and the National Institute of Mental Health, most notably our co-chairs, Drs. Goodenow and Rausch. I'm excited to get today's opening session started, so I will keep my remarks very brief. A few comments about logistics for everyone. First, if you're experiencing any technical difficulties, please reach out to us via the Q&A chat box, which is located on the lower right portion of your screen. Our event producer will quickly assist. Please also see any instructions in the webinar notes in the upper right. Second, if you haven't already, and you click on the microphone drop-down button and you select Connect My Audio, please be sure that you are muted, or our event producer may mute you if you forget. Third, during question and answer sections of the day, you can submit your questions via the Q&A box, or you can click on the raise hand icon, which is located at the top of your screen. Questions submitted via the Q&A will go to the moderators and presenters. Please feel free to submit questions throughout the event, and we will do our best to address all the questions. But some may need further discussion moving along in our virtual work groups. And then finally, an unedited recording of this webinar will be shortly available by the end of the week or early next week if you miss some of the sessions. We will publicly post high-quality recordings that are 508 compliant sometime this summer. So I think that covers logistics for now. Let me just end by saying that I really appreciate and thank you for your willingness to engage with us today and over the summer as we take an unflinching look at the subject matter. It's important for us to think critically and carefully as we consider and perhaps reconsider our understandings and our directions. I think we all share a bias toward action, and so at that, I'm going to let us get started, and I'll turn it back to Paul. Thank you.
Thank you, Greg. It is now my honor to introduce our first welcoming speaker and co-chair of the workshop, Dr. Maureen M. Goodenow. She was appointed Associate Director for AIDS Research at the NIH and Director of the NIH Office of AIDS Research in 2016. In this role, Dr. Goodenow leads the OAR in coordinating the NIH HIV/AIDS research agenda to end the HIV pandemic and improve the health of people with HIV. In the past 4 years, Dr. Goodenow has redesigned and retooled the OAR as well as the NIH HIV/AIDS research program overall. Her emphasis is consistently on innovation, diversity, and impact across the program, as well as in NIH's work with its many public, private, community, and academic partners. Dr. Goodenow?
Thank you, Paul. And good day to all, and welcome to the workshop, and thank you for joining us today. In particular, the co-chair, Dr. Diane Rausch, and our other opening speakers, Dr. Joshua Gordon and Mr. Harold Phillips. To say this workshop is timely is an understatement. Once again, long-standing racial, social, and economic inequities are at the forefront of our lives, manifested not only through HIV, but also COVID-related, as well as the recent tragic deaths of Breonna Taylor, George Floyd, Ahmaud Arbery, and too many other discrimination and brutality. As a leader in health research, NIH has the mission and responsibility to continually secure the evidence needed to achieve new ways to improve people's health and keep them free from harm and disease. This includes addressing the health consequences of systemic racism, stigma, and health disparities that prevent individuals and communities from experiencing the full and complete life they hope for and deserve. Community members and researchers have long discussed intersectional stigma and discrimination, but systemic and institutional policies ingrained in civil society are also public health issues that affect the well-being of individuals and communities. To the heart of the matter, HIV-related stigma is a critical barrier to the prevention, care, and treatment of people with HIV. Stigma impedes access to and uptake to effective tools to prevent HIV transmission, as well as to fully achieve positive health outcomes and the quality of life for people living with HIV. We also recognize that the nature and intensity of HIV-related stigma may be exacerbated by comorbidities. For example, mental health issues, substance use disorders, and/or pre-existing social inequities. In addition, co-infections, whether long-standing infections such as TB or the current novel coronavirus ravaging the global community. The NIH HIV/AIDS research program's overarching priorities are outlined in the NIH 5-year strategic plan for HIV and HIV-related research. The NIH recognizes the importance of intersectional stigma research in the context of HIV, which is captured through the cross-cutting priority areas of behavior and social sciences and is relevant to all the other overarching priorities. Researchers are making progress to elucidate the effects of intersectional stigma at the individual, community, and structural level. Findings from studies that will be presented today will lay the foundation for the implementation of HIV intervention services and programs that move beyond considering stigma as a unidimensional variant to addressing various forms of marginalization at the intersection of factors such as race, gender, sexual orientation, and socioeconomic status. That brings us to the workshop and our work at hand. The workshop is organized in 3 phases. Today, phase 1 is the opening session, where we will participate in a series of pioneering presentations and discussions that will lay the groundwork for the next 2 phases. Over the next 2 months, phase 2 will be implemented, and that involves 4 online interactive work groups that will meet approximately 3 times to collaboratively address key questions, develop a summary report and presentation, and prepare an outline for a post-workshop meeting report and journal article. The final phase, phase 3, will take place on September 18th when we have our final report out session, and that will be open to the public. This will be a moderated discussion with work group presentations and refinement of key points and next steps. Today, the work of phase 1 is focused on the development of a consensus conceptualization of intersectional stigma and discrimination related to HIV, identification of research opportunities, and ultimately implementation strategies and interventions to address the health consequences of stigma and discrimination. These efforts will be then continued through phases 2 and 3 of the workshop. Many of us here today attended the virtual AIDS 2020 conference last week. Relevant themes of HIV and comorbidities, stigma, and discrimination were discussed, including in the satellite session organized by OAR entitled The Impact of NIH HIV/AIDS Research and Discovery at the Intersection of Prevention, Treatment, and Disparities Across the Lifespan. As we move into our workshop discussions today and over the next few months, we will build on our collective knowledge, experiences, perspectives, creativity, and wisdom. I look forward to the work that will be done at this workshop and its contribution to the progress toward ending HIV. It is now my pleasure to introduce our next speaker in this opening session, Dr. Joshua Gordon. Dr. Gordon became the director of the National Institute of Mental Health in 2016. This NIH Institute is the lead federal agency for research on mental disorders. Dr. Gordon is a psychiatrist and neuroscientist with extensive experience in mental health research and practice. He oversees a broad research portfolio of basic and clinical research that seeks to transform the understanding and treatment of mental illnesses, paving the way for prevention, recovery, and cure. Over to you, Dr. Gordon.
Thank you very, very much, Dr. Goodenough, for the introduction, both to the workshop and to myself. I want to thank you also for your support of the NIMH AIDS research programs over the years you've been here. I want to thank Dr. Rausch, Mr. Phillips, community partners, researchers, and government officials for joining us today and for making this intersectional stigma workshop a priority for you all. I'm sorry that we can't welcome you in person at the NIMH. That would have been wonderful. But I think this workshop is a nice substitute for that, and hopefully it will be more than nice. Hopefully it will set the stage for our efforts to come. Let me just talk to you briefly, if I could have the next slide, about our mission, our vision. The NIMH envisions a world in which mental illnesses are prevented and cured, and our mission is to transform the understanding of treatment of mental illnesses through basic and clinical research, paving the way for prevention, recovery, and cure. This vision and this mission leave unstated what is really crucial, which is that we are committed to improving the mental health of all individuals. As such, this mission and vision is incomplete if we don't ensure that we work hard to reduce disparities and to ensure that all members of society have a voice and have access to care and have access to effective care that works for them. At the NIMH, in addition, of course, to our Division of AIDS Research, which is deeply committed to these issues, we have specifically an Office for Disparities Research and Workforce Diversity. This coordinates the two significant priorities at NIMH most closely related to ensuring that we improve the mental health of all individuals. One is to reduce mental health disparities and promote equity both within and outside of the United States, and two is to further efforts to diversify the mental health research workforce. Unfortunately, mental health disparities remain a persistent public health issue in the United States. That's been if anything, accentuated and highlighted by the COVID pandemic, which has affected individuals of color and from disadvantaged and underrepresented communities, from rural areas, more so than other populations. The mental health disparities persist for racial and ethnic minorities, sexual and gender minorities, individuals from lower socioeconomic strata, those residing in rural or frontier geographic areas. And many of these, of course, are high-risk areas for HIV as well. We have acknowledged and continue to acknowledge that sound mental health research must include a multiplicity of perspectives and approaches from a diverse array of contributors in order to ensure that we address these disparities through our research program. And therefore, our own workforce, our investigators, the individuals, as well as the individuals who participate in NIMH-funded research, should represent these groups. To this end, if I could have the next slide, we have in the new strategic plan that was just released in May, set out many of the expectations for research that we conduct across the board to ensure that it is aimed squarely at this mission of improving the mental health of all individuals in the U.S. This new strategic plan provides a framework for advancing research priorities, not only in disparities, but really across our mission areas. We aim to build on the advances that were accomplished in the previous iteration of the plan. And in this document, we identify areas in the new document where NIMH-funded science can have the greatest impact. I want to point out two features of the plan. First, more relevant to this workshop, that we have a long history of supporting research on mental illness stigma and HIV-related stigma and intersectional stigma. And this is one of the reasons why we want to have this particular workshop. And then the other is that this is a living document that will be influenced by the outcomes of our interactions with the extramural community, including this workshop. So we hope that you will look at this document and look for where we are falling short on declaring the importance of our mission, and help us continually update and revise the strategic plan. We also hope you look at the document to look for scientific progress that we've made along the way, which will be elucidated in the plan as well. I just want to conclude by saying that as noted by Dr. Goodenow, the importance of advancing research and opportunities to measure and intervene to reduce intersectional stigma and discrimination. This is an urgent priority that in light of the mental health burden and massive, really, racial and ethnic disparities that already existed but that have been revealed by COVID-19, plus the long history of institutionalized racism, which has also come to a fore in the last few weeks, that this underscores the importance of our efforts and underscores the importance of the workshop that you'll be participating in. With that, I'll just hand the microphone over to Dr. Diane Rausch, Director of AIDS Research at NIMH. I'll spare you the long introduction, but I will say that Diane really has been at the forefront of ensuring that our AIDS research that we conduct here at NIMH is thoughtful in this particular area of ensuring that we help all Americans and really individuals all around the world. And so I'll leave it to her to for further remarks. Thanks.
Thanks, Dr. Gordon, and thanks, Dr. Goodenow and Mr. Phillips for participating in this opening panel. And thank you to all the participants, our community partners, researchers, and government officials. And thanks for taking the time to be with us today. Just to give a little overview, the Division of AIDS Research at NIMH has a very broad mission, which is to support research to reduce the incidence of HIV/AIDS worldwide and to decrease the burden of living with HIV. And DARE-supported research encompasses a broad range of studies, from basic and clinical neuroscience to basic and applied behavioral science within the context of HIV prevention and treatment and cure. An important part of this mission, important part of this mission is looking at stigma. NIMH has been recognizing the importance of stigma from very early on in the epidemic, and it has been included in our priority setting for since the beginning of our work here. And this includes understanding and addressing the impact of stigma and other social determinants of health as they relate to HIV prevention and treatment for socially disadvantaged populations. So just a little history behind how we got here today. In 2015, efforts were underway to update the U.S. National HIV Strategy, which was developed in 2010, and to build a plan for 2015 to 20. And building on the many advances in HIV/AIDS research, during those discussions, the importance of stigma again was identified as a continuous problem that needed to be addressed. And we thought we should develop a meeting to really look at what has been learned and where the gaps in the research are and how to build on that to move forward. So when we started talking about a meeting, we were partnering with the team from the both the Office of AIDS Research at NIH and the White House Office of National AIDS Policy, as well as the NIMH staff, and we began to develop an agenda for a conference. And as we were developing this agenda, the expanded interest was continued to grow, and so it was thought that this needed higher visibility than we could do. So it became the White House meeting on stigma, which focused on what we know about potential interventions, measures, and actions to counter it. So the meeting goals of the 2016 meeting were to review best practices for measuring and monitoring stigma, evaluate current interventions to reduce stigma and improve health outcomes, and to identify gaps in our understanding. This conference brought together researchers and stakeholders from around the U.S. as well as around the world, including representatives from federal agencies, leading academic institutions, the legal community, advocates, and ministers, for a rich conversation about this complex and multifaceted issue. Participants discussed best practices for measuring and monitoring stigma, as well as methods of intervention focused on reducing or overcoming stigma in order to improve HIV outcomes, and identify problematic gaps in our understanding. One of the most emergent priority themes was the intersection of HIV stigma with other forms of stigma and discrimination, such as those related to sexual orientation, gender identity, mental illness, substance use, socioeconomic status, and race and ethnicity. So we felt that from that meeting that we needed to take a deeper dive into the research, and in 2017, NIMH, Fogarty, and other NIH partners hosted a workshop, The Science of Stigma Reduction, New Directions for Research to Improve Health. And during this meeting, we brought multidisciplinary experts together to look at what's been done and identify an agenda for stigma research in global health. So as a result of that meeting, it was decided that we would do an RFA on intersectional stigma. And the goal of this RFA was to improve HIV prevention continuum, and this was done as a collaboration with NIMH, NIMHD, the Office of Health Disparities, and the Office of Behavioral and Social Science Research. And that's where the PRISM RFA, Promoting Reductions in Intersectional Stigma. Okay, so this RFA sought to advance measurements of intersectional stigma and examine the mechanisms, and pathways by which it impedes prevention outcomes in heavily stigmatized populations. And it was to look and develop and test interventions to improve HIV prevention outcomes among target populations in the U.S. and worldwide. And the goals that were the asks in the RFA were that the investigators apply the concept of intersectionality that multiple stigma identities or multiple discriminating forces should be clearly defined and justified, and the proposed population should be limited to key populations who are at substantial risk of HIV acquisition and experience high rates of stigma and discrimination. So NIMH, NIMHD, OVSSR, and NINR, nursing research, are together supporting 8 awards, and we'll hear more about some of these awards from the study team's PIs during the presentations today. So DAR continues to be very interested in theoretically driven research to advance measurements of intersectional stigma or discrimination, to examine the mechanisms and pathways by which they are barriers to HIV prevention and treatment, and to develop and test interventions to address their impact to improve prevention and treatment outcomes. So I'm now happy to introduce Harold Phillips, the Senior Advisor and Chief Operating Officer for Ending the HIV Epidemic, A Plan for America at the Office of Infectious Disease and HIV/AIDS Policy in the U.S. Department of Health and Human Services. Mr. Phillips has held many leadership and advisory positions among many components of the government, including HHS, PEPFAR, HRSA, CDC, and others. He's been a great partner and a good friend and an advocate and brings much experience to our science. So welcome, Mr. Phillips.
Thank you, Diane, and thank you also to the Office of AIDS Research and the National Institutes of Mental Health for this important workshop, and also, as Dr. Goodenow said, also very timely workshop. I'm going to talk a little bit about EHE, but also I'm going to talk about this moment in time and how important this work is, and the fact that we need to be both solution-focused, but also take advantage of this opportunity to listen to others about what works and really look at the issue of systemic racism and how it connects to stigma and discrimination. Many of you have seen this slide before about EHE, the Ending the HIV Epidemic initiative, and our overall goals of the 75% reduction in 5 years and the 90% reduction in new transmissions within 10 years. The initiative itself sits on 4 pillars: diagnose, treat, prevent, and respond. And by working within these pillars, we believe that we will be able to make a difference and achieve the goals of the initiative. We've done numerous studies on the impact of stigma in public health that sort of show how it detracts and keeps us from meeting our overall goals, both within the EHE initiative, but also within the National HIV Strategy, and how stigma impacts how the way those racial and ethnic minorities, sexual minorities, immigration status, how all of that sort of impacts accessing and remaining in both prevention and care services. When EHE first started back in February 2019, the federal government initiated a series of listening sessions across the country. And some of the things that we heard that need to be addressed, stigma was one of those. And really taking a look at how we could combat stigma and address it within our service delivery systems. EHE calls for the communities to come together and be innovative and develop innovative approaches that will help us meet the goals of the initiative. At this point in time in our history, it is both encouraging the number of dialogues that have been happening and taking place, and there seems to be this deeper willingness to have a deeper understanding of the impact that 400 years of trauma have caused among people of color and how systemic racism plays a part in all of this. I think, as many of our previous speakers have said, COVID-19 also gave us the opportunity, I think, to stay in place and be open to listening and learning and facilitating those conversations as a result of us sort of seeing on television and witnessing and reading the news reports of the tragic murders that have taken place over the last couple of months. And I think now we're at a place where both we can hear, listen, learn, and really think about what needs to be done and what we can do. It's, I think, coincidental, but I don't believe in coincidence, that we've talked about the National HIV Strategy. Today is the 10th anniversary of the release of that strategy, which also has within it the call for the reduction of stigma and discrimination against people living with HIV as a key step in this overall process. I think the other thing with the strategy is that with the development of the strategy, again, very similar, a number of people from not only the federal government but the community also came together to participate in the development of that strategy. And so as we think about different ways to approach the issues of stigma and discrimination, we've also got to remember that the community has to be at the center and that the community also needs to be part of the solution development as well. We've got a number of solutions that have been developed to reduce stigma over time, both in our Ryan White program and the Bureau of Primary Health Care. We also have a number of policies and procedures that have been in place. And yet we still recognize that it's not enough to just have those in place, that there must be more that is done. Some of the studies that we have had in the past also include different ways to do needs assessments and figure out what the community needs and what the community is saying. We have a group of folks within the community, and I think you're seeing it as we sort of learn more, that they, in the face of these challenges, have developed tools for resilience and are resilient and often can rise above. How do we capitalize on that as we sort of look at systemic racism and stigma and discrimination? How do we build upon the strength of the communities that we have? How do we look at some of the basic services such as housing and transportation that get in the way, and how do we deal with that? How do we deal with the issues of trauma that are also impacting the ability of populations to access and remain in prevention and care services? How do we develop messages that are affirming and positive and feature faces that are familiar to individuals? And how do we utilize social media and technology? There are a lot of ideas for consideration. I think we'll have more as a result of this. I challenge us to become solution-focused, to continue the dialogue and the hopeful path that we are on. Also, this is a whole-of-society initiative for EHE. I commend my other federal colleagues for being part of this and for facilitating the dialogue and for being willing to listen and learn. And I look forward to the solutions that we can enact on the local level, and that at the federal government we continue our work to create a framework and a platform for these dialogues to happen. But again, the solutions have to be locally driven, and I encourage us all to work together to end the HIV epidemic. Thank you.
Thank you, Harold Phillips, and to all our welcoming speakers for these very important points for us to consider and take forward into this workshop and beyond. And moving forward, I would like to introduce the moderator of our first panel, Dr. Valerie Earnshaw. Many of you know her, have worked with her, or know of her work. She is an associate professor and a faculty scholar in the Department of Human Development and Family Services at the University of Delaware. She will be the moderator of our next panel on conceptual frameworks. Dr. Earnshaw?
Good morning. Hello, everyone. It's my pleasure to moderate this session on conceptual frameworks. We are going to hear from two speakers this morning who will lay a foundation for us in intersectional stigma. During the presentations, please add your questions to the chat box, and then after the presentations, I will raise them to our presenters. First, we will hear from Dr. Lisa Boleg. Dr. Boleg is a professor of applied social psychology in the Department of Psychology at the George Washington University. She is also director of the Social and Behavioral Sciences Core at the DC Center for AIDS Research and the founding director of the Intersectionality Training Institute. After Dr. Boleg, we will hear from Dr. Ann Stengel. Dr. Stengel is a social and behavioral scientist, president of HERA Solutions, and associate faculty with the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. So Dr. Boleg, I'll turn it over to you to get us started.
Thank you, and good morning. I would like to thank NIMH and the Office of AIDS Research for the opportunity to participate. In particular, I'd like to give a special thanks to Dr. Greg Greenwood for all of his work in bringing us all together to talk about intersectional stigma. So I'm going to be speaking very briefly and giving sort of an overview of, okay, next slide please. About what I want to do is give a general overview of intersectionality, sort of intersectionality 101, I like to call it. And then I want to talk about intersectional stigma and intersectional discrimination and sort of really give a sort of conceptual overview of those terms, as well as some challenges and criticisms and things that I hope that we will discuss over the day as we try to get on the same ground with discussions with definitions of intersectional stigma. Then I want to talk about the importance of prioritizing structure and system when we talk about intersectional stigma. And finally, I will conclude with a host of questions to guide us as we talk about what do we really mean when we're talking about intersectional stigma and discrimination. Next slide, please. And the next one. Thank you. I always begin when I talk about intersectionality here, because this is really where intersectionality begins. And this is Sojourner Truth, who I like to consider the original intersectionality theorist. And Sojourner Truth is speaking in 1851 at an Akron Women's Rights Convention. And this is her famous speech about Ain't I a Woman, and this is just sort of a snippet of it. That man over there says that women need to be helped into carriages and nobody helps me, and ain't I a woman, and this is really, you know, she just continues this refrain. And she's clearly a woman, but the issue that she's articulating is that because she's a black woman, she is not entitled to all of the rights that white women have. And so I think it's really important that when we think about intersectionality, we're talking about a framework that comes out of sort of the lived experience of women like Sojourner Truth, and one that's picked up by black feminist activists. And what's so tricky for us is trying to apply this framework that was not meant for research to do research. Next slide, please. And so this is one of many definitions of intersectionality, and it's one I advanced in an article in American Journal of Public Health in 2012. Basically, what intersectionality is this sort of a critical theoretical framework or analytical framework. I like to think about it as such rather than as a theory per se. And what it seeks to do is it says that people's individual level experiences, their micro level experiences, really reflect interlocking discrimination or oppression at a larger macro level. So it's sort of the intersection of racism and sexism and heterosexism and classism and ageism, and as you can see, we can go on and on. Next slide, please. So in terms of stigma, sort of the original conceptualization of stigma comes out of sociology, and this is Irving Goffman with this famous book. And stigma, as Irving Goffman saw it, was really something that was discrediting, that was in the individual, this notion of a spoiled identity. Stigma is the situation of the individual who's disqualified from full social acceptance. And this person, the stigmatized individual, is reduced in our minds from a whole and usual person to a tainted, discounted one. And so this notion, this sort of individualistic notion of stigma, is really sort of found its way into how we're talking about stigma, even when we're doing so intersectionally. Next Next slide, please. And so this article is this fantastic review of stigma that I find quite insightful and very important to the work that we're going to be doing in this workshop. In this article, Bruce Ling and Joe Phelan talk about some of the problems with stigma that really sort of resonate with sort of some of the issues I'm having with it in my own work. Next slide, please. So one of the things they say that's problematic with stigma as a concept is that we end up focusing mostly on the individual and not on the people who are doing the stigmatizing. So the quote in this article, the term stigma directs our attention differently than a term like discrimination. In contrast to stigma, discrimination focuses the attention on the producer, so the person who's doing the discrimination, the actual actors. Go back, please. Yeah. Rather than the people who are the recipients of these behaviors. Thus, the terms we use could lead to different understandings of where responsibility lies. And so one of the problems with intersectional stigma, as I see it, is that so much of that puts the focus on the individuals, our language, when we're talking about stigmatized people with stigmatized identities, rather than the people who are discriminating and doing the stigmatizing based on those identities. Next slide, please. So two sort of points. There are lots of points. There are lots of points, but I want to focus on two problems. One of the problems with intersectional stigma is that a lot of the definitions we have are vague. They don't really sort of get at what exactly are we talking about when we talk about intersecting stigma. And as I said, they often focus on the individuals. This, for example, is the definition of intersectional stigma, or a parenthetical definition produced in the concept clearance for this term. And it describes intersectional stigma as multiple stigmatized identities, which sort of gets to some of the issues I was just talking about, but linking Phelan. Next slide, please. The other issue with many conceptualizations of intersectional stigma is that they ignore the role of power and structure. And from an intersectionality perspective, there's no way that you can be talking about intersectionality without talking about power and structure. And I highlighted this article because this is something that Richard Parker and Peter Eggleton pointed out in 2003 when they were talking about HIV stigma and the importance of bringing back power and domination to our work on stigma. One of the things they asserted in this article, we need to reframe our understanding of stigmatization and discrimination to conceptualize them as social processes that can only be understood in relation to broader notions such as power and domination. This sort of focus on social processes such as discrimination. Next slide, please. So I want to talk about some sort of benefits of talking about intersectional stigma or intersectional discrimination, whatever we call it, but making sure that we're doing it in terms of structure or systemic approaches. And here I turn to Kim Blankenshaw's work on structural interventions, and the way that Kim Blankenship and colleagues define structural approaches is that these are approaches that locate the source of public health problems in the social, economic, and political environments that shape and constrain the ability of individuals to sort of engage in health protective behaviors. This is an approach that really sort of fundamentally shifts how we define problems and also the interventions that we take to them. Next slide, please. So one benefit of a structural approach to intersectional stigma is that most of the barriers that we're talking about, whether it's HIV prevention or COVID-19, these are structural problems, right? I mean, there's so many overlaps between COVID-19 and HIV. And so this is a headline from the Washington Post. Income emerges as a major predictor of coronavirus infections along with race. Of course, when we talk about race, right, that's sort of problematic too, because that's sort of putting the problem within the individual rather than what we're really talking about from a structural and intersectional perspective is racism and structural racism and how that imposes sorts of barriers that constrain the opportunities for individuals to protect themselves and their communities from whether it's HIV risk or COVID-19. Next slide, please. Another advantage of talking about intersectional stigma and intersectional discrimination through a structural lens is that it allows us to focus on the root causes. This is a chart from the New York Times a few weeks back where they looked at different gaps between white people in the U.S. and black people across a variety of metrics. So whether it was household income, unemployment, home ownership. And when you sort of pull back, it is not at all surprising that so many of the inequities that we see, whether we're talking about HIV prevention and HIV treatment or COVID-19, are sort of traced to a lot of these inequities that have structural underpinnings, intersections of structural racism, structural poverty, just interlocking. And so I think that there's a real opportunity for us to go sort of bolder as we look for solutions to many of the problems that we'll be discussing today. Next slide, please. The other issue or the advantage of talking about intersectional stigma and discrimination using more of a structural lens is this really important point that Greta Bauer, who is an intersectionality scholar and epidemiologist, makes in her work about why, when we're talking about intersectionality, it's important that we focus on social processes, sort of same thing that Parker and Aggleton talked about. What she says is focusing primarily on social identities, this notion of stigmatized identities or positions, runs the risk of continuing to reinforce the intractability of inequity, albeit in a more detailed or nuanced way. This notion that, people are, your skin color is what your skin color is. Your race is what it is. Your sexual minority status is what it is. Your gender identity status is what it is. And so focusing on those which are really not modifiable, nor should they be, is problematic rather than focusing on things that we can modify. We can intervene against stigma and we can intervene against discrimination and people who are doing the stigmatizing and the discrimination. Next slide, please. So what I want to do now is lead just a bunch of different questions that I just want to sort of throw out that I think that we need to talk about. One of them is, rather than focusing on sort of on individual identities or stigmatized identities and vulnerable populations, sort of flipping the script and asking, what are some of the structural facilitators and barriers to HIV treatment and prevention? From whose vantage point are we censoring or defining problems? A core tenet of intersectionality is that when we are looking at any problems, our starting point has got to be the group that is, most oppressed, or that we look at and we want to understand from their position, not in terms of how they fare in terms of more privileged groups, but really trying to understand all of the barriers and everything from their perspective. Who has the power to implement the changes we seek? Often we expect changes from groups that just do not have the power. How have we engaged the community, particularly community-based organizations who have been doing this work from the start and who are sort of rendered vulnerable by structural inequality? What types of intersectional discrimination do we need to be focusing on? Are there ones that are riskier for certain groups? What structural interventions are possible? And what are the sources of strength, the assets, the resilience that already exist in communities that we can harness to prevent HIV and also COVID? I will end there. Thank you.
Wonderful. Thank you very much, Dr. Bullag. We are now going to turn things over to Dr. Stengel.
Hi, everyone. Good afternoon.
It's my pleasure to be here with you today virtually to talk about the Health Stigma and Discrimination Framework and its implications for intersectional stigma research. So the idea for developing a cross-cutting health stigma and discrimination framework emerged in 2017 at a meeting of health stigma researchers that was hosted by the NIH Fogarty Center and NIMH that Diane mentioned a bit earlier. At this meeting, we discussed how researchers studying health-related stigma have tended to focus quite narrowly on a specific disease or health condition. This approach has led to theoretical silos despite the fact that the stigmatization process is fairly similar across health conditions and contexts. So for example, we identified 7 obesity frameworks, 7 HIV stigma frameworks, and 5 mental health stigma frameworks when preparing the framework paper. So in addition, health stigma frameworks tend to concentrate on psychological pathways among individuals. Few explore the social and structural pathways leading to stigma, and few include intersectional stigma. As a result of this, current health stigma frameworks really limit researchers' ability to inform the multi-level interventions required to meaningfully influence the stigmatization process. This siloed approach impedes comparisons across stigmatized conditions, and it also impedes research on innovations to reduce health-related stigma and improve health outcomes. So in response, we developed the Health Stigma and Discrimination Framework, which was published in early 2019. The framework builds from existing conceptualizations of health-related stigma and from practical experience of the co-authors in designing stigma reduction interventions for a range of health-related stigmas. I just want to take a moment here to acknowledge my co-authors who you see pictured here. Collectively, we brought experience from stigma research on mental health, HIV, leprosy, cancer, tuberculosis, and obesity, and I think the resulting framework really benefited from this diversity of experiences. Our intent was to provide a broad orienting framework similar to Perlin's stress process model to give conceptual organization to diverse lines of research that are underway across disciplines. So I'm going to spend several minutes on this slide in order to walk you through the process and define some of the key terminology. The Health Stigma and Discrimination Framework articulates the stigmatization process as it unfolds across the socio-ecological spectrum in the context of health, which can vary across economic contexts in low, middle, and high-income countries. The process can be broken down into a series of constituent domains, including drivers and facilitators, stigma marking, and stigma manifestations, which influence a range of outcomes among affected populations, as well as organizations and institutions that ultimately impact health and society. The first domain refers to factors that drive or facilitate health-related stigma. Drivers vary by health condition, but are conceptualized as inherently negative. They can range from fear of infection through casual contact for communicable diseases to concerns about productivity due to poor health for chronic conditions to social judgment and blame. Facilitators, however, may be positive or negative influences. For example, the presence or absence of occupational safety standards and protective supplies in health facilities can minimize or exacerbate stigmatizing avoidance behaviors towards populations with infectious diseases by healthcare workers. Drivers and facilitators determine whether stigma marking occurs, in which a stigma is applied to people or groups related to either a specific health condition or a other perceived difference, such as race, class, gender, sexual orientation, or occupation. Intersecting or intersectional stigma occurs when people are marked with multiple stigmas. So once a stigma is applied, it manifests in a range of stigma experiences and practices. Stigma experiences can include experienced discrimination, which refers to stigmatizing actions or omissions, for example, failure to include ramps for people with disabilities, that are prohibited under international human rights law, for example, losing housing because of one's HIV status. Experienced stigma refers to stigmatizing actions that fall outside the purview of international human rights law, such as double gloving or avoiding frequenting somebody's business. Another stigma experience is internalized or self-stigma, which is defined as a stigmatized group member's own adoption of negative societal beliefs and feelings, as well as the social devaluation associated with his or her stigmatized status. Perceived stigma, which refers to perceptions about how stigmatized groups are treated in a given context, and anticipated stigma, which refers to expectations of bias being perpetuated by others if their health condition becomes known, are also classified as stigma experiences in our framework. Lastly, secondary or associative stigma refers to the experience of stigma by family or friends of members of stigmatized groups, or among healthcare providers who provide care to members of stigmatized groups. That's also included under stigma experiences. So now let's take a look at stigma practices. Stigma practices can include stereotypes, prejudice, stigmatizing behavior, and discriminatory attitudes. In the framework, we consider stereotypes and prejudice as both drivers and manifestations, as they both fuel and are reinforced by the stigmatization process. We postulate that stigma manifestations go on to influence a number of outcomes for affected populations, including access to justice, access to and acceptability of healthcare services, uptake of testing, adherence to treatment, resilience, or the power to challenge stigma and advocacy. They also influence outcomes for organizations and institutions, including laws and policies, the availability and quality of health services, law enforcement practices, and social protection. While the framework is specific to health-related stigma, it recognizes that health-related stigma often co-occurs with other intersecting stigmas, such as those related to sexual orientation, gender, race, occupation, and poverty. Incorporating intersectional stigma into the framework is necessary, as stigma manifestations and health outcomes may be influenced by a range of stigmatizing circumstances that must be considered to understand the full impact of stigma. So what's different about the framework? The health stigma and discrimination framework differs from many other models in that it does not distinguish the stigmatized from the stigmatizer. The absence of this dichotomy is intentional, as we seek to challenge the us versus them distinction that enables people to set others apart as different from the norm, a key component of the stigmatization process. We seek to move away from psychological models that see stigma as a thing which individuals impose on others, and instead emphasize the broader social, cultural, political, and economic forces that structure stigma. Removing the us versus them dichotomy also makes the framework more palatable to change agents, such as community leaders, advocates, and policymakers, as it highlights that all persons can act as change agents and underscores the need for self-reflection and awareness of biases. Another difference from previous frameworks is the separation of manifestations into experiences and practices. This distinction clarifies the pathways to various outcomes following the stigma marking phase of the process. Those who experience, internalize, perceive, or anticipate health-related stigma face a range of possible outcomes, such as delayed treatment, poor adherence to treatment, or intensification of risk behavior that may diminish their health and well-being. Stigma practices, on the other hand, highlight how the stigmatization process can generate or reinforce stereotypes and prejudice towards people or groups living with or at risk of various health conditions, and foster discriminatory attitudes that fuel social inequalities. We also differentiated outcomes for affected populations from outcomes for organizations and institutions. Our framework seeks to demonstrate that stigma experiences and practices influence both affected populations and organizations and institutions, which then together affect the health and social impacts of stigma. By articulating these outcomes, the framework highlights the need for multi-level interventions to respond to health-related stigma. It also focuses attention on the far-reaching influence of health-related stigma on societies as well as individuals. So how do we use the framework? One way is to guide the development of interventions. The framework can be used as a tool to facilitate discussion among researchers, program implementers, and policymakers. For example, key questions to discuss include: what are the drivers of specific health-related stigma and discrimination in a specific country or context? What are the facilitators? What other stigmas may intersect with the health-related stigma? How does the health-related stigma manifest? Answers to these questions can help determine where public health practitioners, clinicians, and policymakers should focus their efforts. Okay, in terms of where to intervene, ideally we want to stop stigma marking from occurring.
So interventions often focus on the drivers and facilitators of stigma. While we would like to prevent stigma from being applied, we also need to be prepared to deal with the manifestations of stigma. This could include psychosocial support for people living with a specific health condition or legal aid to cope with discrimination. It could also include training for healthcare providers or police to overcome stereotypes and discriminatory attitudes, or the development of new laws or policies to protect against discrimination. In addition, it's our hope that the framework will enable stigma researchers across disciplines to standardize measures, compare outcomes, and build more effective cross-cutting interventions. Researchers can use the framework to generate research foci, to explore multiple health issues, and consider the intersections between multiple identities, social inequalities, and health issues. Implementation science approaches can advance how we tailor and apply the framework to guide stigma and discrimination reduction interventions and policy. So what are the implications for intersectional stigma research? The health stigma and discrimination framework can also inform discourse and action to address intersectional stigma. However, you need to include a broad range of stakeholders in discussions about intersectional stigma, not just health experts. The stigmatization process is ubiquitous, so the framework applies regardless of whether it's a health-related stigma or an identity or social stigma that is being discussed. The social impacts of stigma and discrimination are just as important as the health impacts. Therefore, addressing the intersectional stigmas that combine to create either advantages or disadvantages for people is critical if we are to achieve both health equity and social justice. So in conclusion, the health stigma discrimination framework can be used to develop or adapt interventions to address health-related and intersectional stigmas at multiple socioecological levels. We believe that research and interventions inspired by a common framework will enable the field to identify commonalities and differences in stigma processes across diseases and identities and amplify our collective ability to respond effectively and at scale to this major driver of poor health and social outcomes globally. Thanks very much.
Terrific. Thank you very much, Dr. Spengel. Dr. Boleg, I think you can come back and join us. We have a few minutes for Q&A. So I'd like to invite folks in the audience, if you have questions, to feel free to use the Q&A feature, and I can read out your questions and or just raise your hand, and we'll invite you to ask your question. I don't see any questions yet, so I'll kick us off. So Dr. Boleg, I was reflecting on your comment that we are applying a framework that was not meant for research to research. And I was curious, and both of you have touched on this a little bit, about, from your perspectives, what are researchers and what are interventionists missing generally when they're applying these conceptual frameworks to their work? So in other words, what are some of the blind spots that we may be having that we should think about in our work groups? These blind spots that might be preventing us from moving this agenda forward?
Mm-hmm. Well, one of them would be that a lot of social behavioral scientists are trained in these sort of individualistic disciplines, right? So I'm a social psychologist by training, and so all of my training, whether sort of methodology, theory, is very much individualistic focused, right? And so when we're talking about this sort of complex multi-level, that it's the individual within the context of the sort of structural forces, you know, that's when it gets really messy. How do you measure those things? How do you measure, you know, and assess structural racism? How do you, you know, how does that come into the model? And so that's that's a big issue. Another one is just around measurement, right? So the way that we've thought about measurement is in this very sort of unidimensional way. So there are excellent, well-validated measures on racial discrimination and excellent on sexism and, you know, and heterosexism and all of that. But this notion that all of these are interlocking, then how do you assess that in sort of research on stigma? And so those are just sort of two. There are many more, but those are just sort of two of the complexities with trying to apply this to research and intervention work.
Terrific. Dr. Singal, do you have anything to add? I also see we have a question for you in the chat box.
Yeah, no, not much to add to that. I think that was really
Okay,
spot on. I think really we're, it's that issue of how to, dealing with individuals as opposed to the societies in which they live, and I think that's where we need to go. So, yeah.
Great. Well, Dr. Singal, we have a question for you in the chat box, which is, what has been your experience explaining your framework to non-academic audiences? Has it been easily understood? And this is a great question for you because you have good experiences with this.
Yeah, no, actually, that's a great question, and thank you for asking it, whoever asked it. The reason I love this framework so much is actually because it's really easy for people to understand. They can see themselves in it, they can see their communities in it, and it really applies to any kind of stigma, whether it's related to race, whether it's related to health. I mean, of course, we called it the Health Stigma and Discrimination Framework because in that, you know, it was related to it came out of that health stigma research convening, but really it's very widely applicable. And I think people really like to see that we're not sort of pitting the stigmatized against the stigmatizer, that really when you're talking to policymakers, when you're talking to government leaders, that really shuts conversation down when people look at a framework and they see, oh my gosh, well, if I'm not the stigmatized, then I must be the stigmatizer, and it really shuts off conversation. So I think letting people know that anyone can be on either side, right, at any time for different identities, I think that's really, really important. I think it's also really, people like to see that you have manifestations and how these manifest for both the individuals and the institutions and organizations. So you can see how stigma in and of itself sort of leads to these discriminatory laws and practices and policies, discriminatory policing. And so it's a little bit more obvious for people to see, how do I personally, or how does my organization, how does my, you know, whatever it is I do for a living, how is stigma applicable in that context? So I've found it actually pretty useful tool, whether you're talking to researchers or program implementers or advocates.
Great. Well, big thanks to Christina Rodriguez Hart for the question. I should have read that. We do have another from Paul Geist, which is, knowing the interplay of the personal and the social with respect to stigma and discrimination, what would be your guidance on how to best approach the full dimensions of these dynamics? It's a tough one.
Is that for me or for Lisa?
Yeah, it could be for either. Sure. Knowing the interplay of the personal and the social with respect to stigma and discrimination, what would be your guidance on how to best approach the full dimensions of these dynamics?
Well, I mean, I think we know quite a bit about the sort of interpersonal dynamics. We don't know so much about sort of the structural interplay with the interpersonal and the social. And so to give sort of a concrete example, so my team's, our work on intersectional stigma is looking at the intersectional stigma for gay, bisexual, and other men who have sex with men. These are black men, right? I'm very much interested in the way that stigma operates, even in sort of the visual way, the visuals, right? You show up for an appointment, you're sitting in a waiting room. None of the photos or posters on the waiting room look like you. You need, you know, the security guard is asking for 5 pieces of ID for you to get into the clinic. There are all these different ways that structure sort of creates barriers before there's even an interpersonal reaction in the example of the posters. And so I think we need to build off of what we know about what happens in terms of interpersonally, but we also need to look at, okay, what are the consequences in terms of interpersonal stigma? What are the consequences for the physician who doesn't prescribe PrEP because he thinks that, you know, black, gay, bisexual men who have sex with men, that they're more promiscuous, you know, or all of that. What are the consequences? And this is what I mean by coming at it from another direction. I think that we've been too biased towards the sort of individual and interpersonal direction, and we need to do the hard work of trying to understand it from the other level. That would be my answer.
Great. Well, Dr. Singal, we have another.
Yeah, exactly.
Oh, yeah, Dr. Singal, do you have anything to add? Otherwise, we'd have another.
No, I'm okay. I think she's correct. I see we have a lot of other questions, and we only have like 3 minutes. So.
Yeah. Well, from Janet Turan, we have a question. You said that we need to remove the emphasis on us versus them, but isn't that the essence of the stigma process?
Yeah, so that's always the clincher, right? I mean, the process itself, that's what happens. There's a difference based on whatever it is, a disease or a identity, and that causes this us versus them. So that is sort of what happens, but we didn't want to call that out very specifically in the framework. We wanted to sort of show people sort of how these things manifest, what the process is, and where you can stop it. So I think mainly one of the reasons why we did that, like I was saying, is to enable us to be able to foster discourse around this issue, because once you start focusing in on the us versus them, that's the stigmatized versus the stigmatizer dichotomy, and it's not really helpful in moving forward in terms of conversations. So I think depending on what you're doing, obviously what kind of research you're doing, whether you're testing pathways or all of these different kinds of things, it may be useful for you as a researcher to look at that distinction, to look at the people who are experiencing stigma versus the people who aren't. But when you're thinking of this as a tool to inform sort of societal discourse and action and engaging policymakers, we just found it more useful to sort of leave that distinction out.
Great. So let me give a round of applause, everyone, to Dr. Earnshaw, Stengel, and Bolduc for a really fantastic session on the conceptual frameworks. As you can see, there are so many more questions, and we'll have plenty of time in our virtual work groups to sort some of these thorny issues out. But I can tell you, the three of you, how grateful I am for your help. So with that, let me introduce George Ayala. George is the Executive Director of Impact Global Action for Gay Men's Health and Rights. And with that, let me introduce you to George and let George take it away.
Hi, everyone. Thank you so much to NIMH, Office of AIDS Research, and special shout out to you, Greg. I appreciate the invitation. It's a real honor to join you. Can I see the first slide here? There we go. It is really my honor to be a part of this and to share the panel with our distinguished speakers. Next slide, please. Yeah, we can go. In speaking with my colleagues on the panel, can we go back one, please? I guess I could focus on this myself. My colleagues on the panel asked me to open the panel with a couple of opening remarks, and then I'll kind of hand over to them. My first slide here is really kind of a slide about why intersectional stigma research. And the why here is because the social shape of health and health disparities is too often ignored and misunderstood. Health and health disparities, including HIV and more recently COVID-19, are not evenly distributed in general populations. Disease disproportionately affects some groups, and predictably so. Economic disenfranchisement, racism, sexism, homophobia, transphobia, and xenophobia are not mutually exclusive phenomena. They converge to hurt health, and in particular, in this case, HIV disparities bear that out. The multidimensional nature of oppression has important implications for policy, research, and practice. I felt compelled to kind of say a few things about the role of community, and you'll hear our panelists speak to this issue as well. The role of community here is to articulate problems, to theorize about the nature of those problems, and to come up with solutions that are best fit for purpose. Communities partner in policy, research, and practice. And here I think I want to caution our colleagues who are conducting important research not to essentialize the role of community, and oftentimes we see communities sidelined or relegated to community advisory boards or as labor to collect data, but seldom treated as equal partners, which I think is particularly important in stigma research. And also communities expose power imbalances, underlying health disparities, and partnerships formed to respond to those disparities. Here I wanted to call attention to a seminal work, This Bridge Called My Back, and there's quite a bit to talk about. I think their entire course is devoted to this work. But this work surfaces several critical questions which gave rise to contemporary understandings of intersectional stigma. What are particular forms of oppression faced by women of color, socially marginalized groups across a broad range of socio-political situations like war and conflict? And this is a collection of work that intended to reflect an uncompromised definition of feminism by women of color. It contained prose, poetry, personal narrative, and analyses by African American, Asian American, Latina, and Native American women in the U.S. And in doing so, it really expanded, it modeled ways for expanding engagement of different viewpoints and voices to bring additional ideas to bear on the challenges, the day-to-day challenges faced by women of color. In here, there are questions about how are multiple stigmatized identities and group memberships experienced? How are multiple co-occurring forms of oppression experienced? They grapple with another question: in what ways have oppression and suffering been silenced or overlooked? How has oppression impacted families and communities? And how do marginalized groups organize to survive and thrive, to keep bodies, spirit, families, and communities intact? This work, as I said, was published back in 1981 and really precedes Kimberly Crenshaw's very critical work on intersectionality. Here again, I want to draw attention to some of the community work that emanated in the HIV sector in the early 2000s. In 2002, the National Gay and Lesbian Task Force in the U.S. commissioned a monograph titled "Say It Loud, I'm Black and I'm Proud." Authors of the monograph wrote, "Race, gender, class, and sexual orientation are not separate identities. These identities are experienced holistically and intersectionally." And even before, as you see, intersectional stigma was something taken seriously by research communities. Communities on the front lines were already signaling the issue and the importance of addressing that issue in practice. That monograph went on to provide several important recommendations that resonate still strongly today. I want to also draw attention to another piece of work, similarly to the monograph that I just mentioned. In 2006, the Institute for Gay Men's Health, under my direction, published 46%, a special issue of their magazine called The Scarlet Letters. The issue was in response to the startling announcement by the CDC that nearly 1 in 2 Black gay men in the U.S. were living with HIV. In that special issue of the Scarlet Letters, there was an article titled Black Gay Men's Lives Matter, a foreshadowing of what would come. It powerfully imagines an HIV response if Black gay men mattered. We wrote, "If Black gay men mattered, HIV prevention interventions would be democratically developed and framed in the language of love, intimacy, connection, and sex. HIV prevention would honor the knowledge and wisdom Black gay men bring to bear in creating solutions that make sense to their day-to-day realities. We would embrace this knowledge as credible evidence. It goes on to write, if Black gay men mattered, they would be the point of reference as we strategize our HIV responses. We would begin to expose language that shames and isolates. We would identify when and how moralistic attitudes about sex and drug use negatively impact on the lives of Black gay men. Homophobia in its many guises would be exposed. We would unapologetically name systemic racism, class discrimination, and gender violence when it was happening and point out how it was hurting. And so with that, I want to hand over to our panelists, perhaps beginning with Justin Smith from Emory University. I've asked each of the panelists to introduce themselves. So Justin, if you could turn on your mic, and I think Justin and Rafaele will be speaking together. Thanks, guys.
All right. Good morning, everyone. My name is Justin Smith, and I serve as the director of the Campaign to End AIDS at Positive Impact Health Centers, which is an HIV community-based organization in Atlanta, Georgia. And I'm joined with my colleague, Rafaele Narvaez.
Good morning, everybody. My name is Rafaele Narvaez. I'm the co-founder and director of health programs at Latina Salud, and also I serve in PACHA with Justin.
Yeah, Rafaele and I also have the honor of serving as the co-chairs of the Stigma and Disparity Subcommittee of the Presidential Advisory Council on HIV and AIDS, or PACHA. So we just wanted to give thanks to the organizers of this meeting and to Dr. Ayala for really navigating us through this really important conversation. So what Rafaele and I will offer is a community-based perspective on intersectional stigma. I want to begin our conversation this afternoon with a quote from the great Black lesbian poet Audre Lorde. And she invites us to kind of enter this conversation in this way. She says that there is no such thing as single-issue struggle because we do not live single-issue lives. One of the opportunities and hopes that I have for intersectional stigma research is it's really an opportunity for the conduct of HIV research to more closely mirror the lived experiences of the communities to which researchers are accountable. And I think, as has been sort of talked about in the first couple of presentations, it's a framework that can provide empirical data to support the development of the structural interventions that we know are needed to get at the root causes of stigma. As with all research, there are specific challenges. I wanted to just name three. The first is thinking about the vast import of this work and how the work needs to sort of be visible to communities outside of the traditional academic journal route. So what are the types of opportunities that various social media platforms make possible for this audience, for the research to have a broader audience? I wanted to lift up one potential venue for this, which is a podcast that's hosted by one of the mothers of intersectionality theory, Kimberly Crenshaw, which is called Intersectionality Matters. You can find that podcast wherever you obtain your podcast media. The next piece is to think about how, given the importance of this work, how it can be translated quickly into both programmatic and policy solutions. And then lastly, thinking about how community organizations can not just be a part of the work, but actually can lead some of this work. And I know Rafaele has some additional thoughts on this part.
Thank you, Justin. Absolutely. As mentioned before, community-based organizations and serving minorities have a big role in this portion. Somehow, when research gets started, community-based organizations and minorities are never been taken in serious or never been taken as a part of the group. They need to initiate this research. We always end up with, at the end of it, recruiting people for the study, but not being part of the study itself. That creates a stigma, much discrimination. When we try to recruit some of our clients for these studies, they just mention to us, which is one more number, give me a $25 gift card, and you know, they don't really care about how and what we feel on how the work needs to be done with just another number. Thank you, Justin.
Thank you, Raffaele. One other opportunity that I want to name is that doing this work provides an opportunity to really center and acknowledge the contributions of both Black feminist thought, the work of other women of color, and Black women's intellectual labor in really laying the foundation for these conversations. We had a really tour de force presentation from Dr. Lisa Boleg, who's one of the first scholars to really bring intersectionality into public health. So thank you, Dr. Boleg, for your work. I think this also provides an opportunity for us to think about how this work feeds into other types of interventions that are not as sort of popular or thought about in public health, which are connections to art and cultural production, and I'll talk a little bit about that later. I think because this responds to sort of the call to action that Dr. Ayala framed at the very beginning about how Black gay men's lives matter and how that shows up, and that can be done in art and cultural production in a very powerful way. So, you know, as I talk about kind of the importance of art and cultural intervention as a site for this work, we know that that alone will not produce the types of changes that we want to see and we know are necessary. We need to do kind of multi-level structural interventions, and that's something that I hope we will spend more time talking about through the course of these workshops. We know that public policy interventions do have kind of this broader potential reach, but I think what I would offer is that when we think about art and culture, these have a way to really do that sort of deep hearts and minds transformation that we know is also a part of this process to address stigma. I want to quickly lift up 4 examples of what I mean by this. So the first is a production called 1 and 2, which in fact takes its name from a 2016 CDC study that projected the lifetime risk of HIV acquisition among different communities. And what it found is that if we do nothing, 1 in 2 Black men can be expected to be diagnosed with HIV in his lifetime. And this play really takes that as its starting point and provides, I think, a very powerful response to the charge that Dr. Ayala gave us at the outset about how does an HIV response look that makes Black gay men's lives matter. And play offers that in a very forceful way. I co-produced a version of this on Zoom a couple weeks ago. We had a really robust conversation. So again, that's just one example of how we can bring these conversations to community in a way that is resonant with their needs. I'm also involved with a CDC-funded initiative to develop an interactive theater workshop that will talk about stigma as it relates to HIV with Black and Latinx young adults. That will be happening tomorrow, actually, or 2 days. But that also provides another way for community to be engaged and at the center of these conversations. Another example of this is the ViiV Healthcare produced play called As Much As I Can, which was actually scheduled to come to Raffaele's organization down in South Florida, but due to the COVID-19 pandemic, it had to be postponed. This work was developed through a series of qualitative interviews done with young Black gay men living in Jackson, Mississippi and Baltimore, Maryland, producing an interactive experience that centered how Black gay men navigate stigma around HIV. And the last example of this is the cultural phenomenon, the FX show called Pose, which centers the lives of Black and Latinx trans and queer individuals in the 80s and 90s as they navigate their identities and respond to HIV. And this is a way that this conversation is happening on a broader scale within our country. So I offer these as just examples of what this can look like outside of a traditional public health framework. As we talk about measurement, I think it's important that we try to have community engaged participatory methods whenever possible so that community can be involved in conducting this research, particularly as it will also strengthen the internal capacity within these communities. So that capacity building piece is really important. And then thinking about closing the loop, making sure that we respond not just with journal articles, but make sure that the data are presented back to communities in ways that are continent and impactful for them. Raffaele, did you want to add anything here?
Absolutely. For credibility and community trust, we need to see the end results of many of these studies, of many of these projects that it has come. Again, we are part of it. We are recruiting the individuals. The individuals come into the organizations to be part of what the researchers want. But at the end of the day, we don't even get to see the end results of it, which it brings distrust in the community. So how we can, make this connection between one and another if we are not working together. So building capacity between community-based organizations, research, health departments, and policymakers is very, very, very important. I really want to make a note of it, and hopefully we, moving forward, can start working together.
And I know that we'll spend a lot of the day talking about methods, and I think that while it's important that we do sort of deepen our understanding of quantitative methods to help tell this empirical story, I don't want us to lose sight of the power and the value that qualitative methods can bring to this type of work in particular, given the importance of narrative and storytelling and how vital that is to moving this work forward. So as we kind of move towards a close, I want to offer up some additional questions that I have around sort of how something we need to consider. One that I'm particularly keen on is I'm one of the principals in Atlanta that are implementing the federal Ending the HIV Epidemic strategy, and I know Raffaele is as well. And we're really interested in understanding how this work can really interdigitate more fully with the EHE plans that are coming forth, because we know that that's the way that we can move the work forward. So what does that connection look like? I think importantly, and other presenters have hinted at this, and I wanted to bring a finer point to what Dr. Ayala offered at the beginning, is we must be sure that in the conduct of intersectional stigma research, we don't actually reify the structures of power and domination in the conduct of the study that we're doing. So that's really, really important. And I think it's important that we also continue to build connections with people that are doing work outside of public health, as we know that many of the structures that we're talking about are not in the purview of public health. So we need to make sure that we're connecting with people that have purview over those other systems. And as Raffaele mentioned, to continue to build trust with community leaders and policymakers is vital. And I'll leave us with the notion of this work as a form of bearing witness. And I wanted to close with this quote from the great Black gay writer and scholar and just everything, James Baldwin. And he says that I had to accept as time wore on that part of my responsibility as a witness was to move as largely and freely as possible, to write the story and to get it out. And I think that is an apt charge for our work here today, to be those that bear witness to the uprisings and the changes that are happening, and to make sure that the story lives on and that we actually do things to change it. So I'll stop there. Thank you so much.
Thank you.
Hello, good evening from Netherlands. My name is Omar Sharif. I lead the Stigma Index team in the global network of people living with HIV. I'm also a drug user living with HIV, and I'm also an advocate for right-based approach in AIDS response. And in my role as a community activist, we did a lot of research because we always do our advocacy based on evidence that we collected from the field. So I would like to start my presentation with this statement of the situation that we're facing right now. Our community, especially key population living with HIV, has been living with stigmatized and discriminatory attitude from our own society simply because we have different ways to live our lives. And this statement is based on our life experience. PLHIV, as the rest of other members of society, we have various circumstances and conditions to live with. The only difference with us is when we try to live our life based on our circumstances and conditions, the society put us on the bottom of the pyramid of society itself. And this is a fact that the situation is by design and have severely impact to our daily life. And yes, we've been trying to do something about it. We've been talking about HIV-related stigma for more than 3 decades. But still, we are facing the same problem right now. So I think the question I would like to ask is, are we doing what's needed or not? And that's also apply in the context of our topic today, which is intersectional stigma. Are we looking at the right factor that influence intersectional stigma? I think some of our presenters previously mentioned that there's more factors that needs to be taken into consideration. And from our own experience, we do think that there's a lot of socioeconomic factors that's still left out. And we need to look at it more and pay more attention for us to be able to have better understanding on this issue. So we need to start thinking of, should we start looking at the economic capacity, class, educational background, and also gender or sexual orientation when we talk about intersectional stigma. The next point that I wanted to say in this opportunity is when we talk about measurement and intervention. Again, we feel that measurement or investigation process and the result of that process should be translated into concrete action to improve policies and practice. And for us, community, this is the reason why we involve in research, because we want to change the situation based on the knowledge that we have and based on the findings from this investigation or measurement process. But to us, the question that really matters right now is, do we see a good balance between measurements and intervention? I will give you one example. Stigma index, which has been implemented widely worldwide for more than a decade, implemented in more than 100 countries. Again, we haven't seen a lot of effort to use the data that we collected from this process for advocacy or to inform the development of policy or program. So we need to really understand that in the future we need to do or have more balance on measurement and how we can make sure that the result from our measurement will be followed up with concrete action. We recognize that there's a lot of challenge to address findings from the measurement process, and I think it's safe to say that a lot of intervention that was designed or created as a result from the stigma measurement tend to be only addressing a partial issues, and a lot of stakeholders at the national level tend to choose the safe way in addressing the result. Most of the follow-up action from the findings is awareness raising or building or improving the capacity of healthcare workers, but it's very rare that we see human rights related issues or criminalization issues is follow up appropriately after the finding is published. And another thing I want to mention about measurement and intervention is also there's a lack of focus on internalized stigma among PLHIV. And this is based on our experience. We know it's extremely hard to change the world around us, but we can change ourselves. And to me, that really contributes significantly in improving the quality of life of our community. We need to really think of how we can address this issue of internalized stigma among PLHIV, and how the connection between internalized stigma and the environment outside us. Maybe we never know if in a setting where most of the PLHIV community have managed to deal with their self-perception on living with HIV, we would love to see how the society around that particular community in that particular setting react to that kind of attitude from the community itself. And lastly, I wanted to briefly highlight on community engagement in research and engaging with researchers. I think George mentioned in the opening of this session that we still see some issues in our engagement, but for us, again, our position is very clear that PLHIV community is the end beneficiary of HIV-related research, and we need the space which will allow us to specify our priority throughout the process. So I think what we really want to see in the future is the collaboration between researcher and PLHIV community needs to be shaped based on mutual benefit. We want to see more, balanced power dynamics, not, just assign us to sit on the advisory board or just to collect the data, go out to the field and collect the data. But we want to also contribute our thoughts and to let you know that this is what we want the process to focus on. And I think we also want to have some sort of knowledge transfer process happening when we engage with research and researcher, because for us it's important to build our own capacity and especially this technical skills and ability in having or being able to collect data and to do it so the data can it's presentable and reliable. It's very important for our advocacy work. I think I'm going to stop in here, and again, thank you so much for the organizer for giving us the opportunity to share our thoughts. Thank you.
Thanks so much, Omar. I really appreciate it. We have been granted another 5 minutes, so we're going to be continuing into our break time. So our apologies. I hope you all will hang in there with us. And Laurel's up next. Laurel, would you introduce yourself?
Yes. Hello, colleagues. It's an honor to be here, and I was hoping we would be granted 5 additional minutes. I'll try to be brief. My name is Laurel Sprague, and it's wonderful to be with so many respected colleagues. Some I've known for quite some time. I've decided to introduce myself by saying that I've been involved in a participant observation HIV stigma study for 3 decades. And those who know me will track that that means that I was diagnosed almost 30 years ago with HIV, and I've been participating and observing what it means to experience HIV stigma in the time since, largely working with networks of people living with HIV. Sorry, I can see my lighting just got weird. I should say good evening from Geneva to everyone who is here. Although most of the research I've done has been as part of networks of people living with HIV in communities,
I'm no longer in a community group now. I work for the Joint UN Program on HIV and AIDS, leading the Community Engagement Division. So let me just share a few thoughts that I've been working on as I think about intersectionality and HIV and stigma and communities. And I'd like to start by reflecting for a minute on an article that George and I wrote a year or two ago with a few co-authors on participatory praxis in HIV stigma research, in which we argued something that I think we firmly believe, which is that, well, much research, maybe all research, should be community-led and should prioritize the needs of communities. This is especially true when we're talking about stigma research because of the specific power dynamics that devalue people in stigmatizing processes, and how essential it is that we don't reinforce those power dynamics in our stigma research processes. And so stigma research needs to be, to the extent possible, community-led in a participatory way. For communities, as I think we all know, what's happening with HIV stigma is not theoretical, it's real. And so putting communities not only at the center but in the driving seat really allows the research to meet the needs of communities but also to be grounded in these realities. I think it's important to reinforce what has been said, which is that what's happening in a stigmatizing process is not that there's nothing neutral, and this is also how I would frame this. Stigma is inherently about power relationships and dynamics. So it's not just that some people are devalued when stigma happens. Other people are, we could say, pro-valued. And this is why I say there's no neutral ground. You're either giving people extra concern and appreciation, or you're diminishing and devaluing them. And so one thing that we ask in this article, and that I would ask here to all of us who conduct research from whatever position we're in, is to be reflexive about our position, and to think about how that impacts our research, and even more to think about that in terms of intersectionality. And as I've written in my notes, intersectionality, not just for objects of research, also those who are behind the microscope. We also occupy an intersectional space and have an intersectional identity. We need to be reflexive about that. I want to raise a couple quick challenges, at least as I see them. In intersectionality research on stigma, it seems that we're looking at multiple axes of identity by which people are devalued. We're thinking about intersecting stigmas. But I'd say that that isn't quite right, because intersectionality isn't, as I said earlier, only about devaluing, but it's also about pro-valuing. And I would say that by ignoring what is pro-valued, we continue to normalize the processes that privilege certain characteristics like whiteness, heterosexuality, maleness, economic security, and more. And we miss the full picture of how stigma actually works. We end up putting people in individual boxes related to HIV of bad off, worse off, even worse off, and way worse off. And these are often the only options for people living with HIV and stigma research. I don't want to say that we should stop focusing on those who are at the receiving end of the most mistreatment, because we need to make that stop. But we're missing, I would say, the full picture of people's resilience, their community membership, their engagement, the kinds of social regard that they may receive in some spaces of their lives when we're only putting people into these boxes. If intersectionality is only about the ways in which people are devalued. And I would say for people living with HIV, we become objectified in that kind of a research lens. Quickly, in terms of identity and intersectionality, we all have these multiple identities that we can identify with, and some of them are more salient at some times than others. And I don't think our research processes around stigma have yet thought through, and tell me if I'm wrong, I hope so, but have yet thought through how to manage this. And salience of different identities changes based on what's happening around us, and what we decide is most important about our identity matters at some times. Also, how other people around us look at us and see which elements of our identity are most salient can change depending on outside circumstances. I could say a lot more, but I won't. But I do want to say that characteristics that are devalued can also become a source of strength for some of us, especially when we connect with others
in similar situations. And I think we have to, in line with this, think about the role of networks, of people living with HIV networks, gay men networks, other LGBT networks, et cetera, and the role they play in self-empowerment, support, and activism and resilience. And then I'll just say quickly, without more comment, that the research logic and methodology that we have around intersectionality right now traps us. Most of the analysis methods we have work exactly against an understanding of intersectionality and complexity and wholeness. So just let me conclude after noting these challenges, that I think these challenges will be interesting for all of us to wrestle with, and they really reinforce the point I started with, which is that it is essential to have community leadership and engagement in the research process around stigma research, because it's the communities at their best, of course, that can hold space and recognize the multiple identities and challenges related to those identities and privileges related to those identities that we are all managing, and that it is the communities that can best hold space for us as whole human beings with the dignity that we hold, or that we inhabit, as we think about research and interventions to understand and address HIV-related stigma. So thank you very much for the time and attention, and looking forward to whenever we get to talk more about these issues.
Thanks so much, Laurel, and thank you, Justin and Rafaele. I really appreciate it. I wish we had a little bit more time to do a little bit of a discussion. Each of you have raised some very, very important issues and questions that I hope we'll take forward in the rest of the workshop. So thank you very much. I'll hand it back over to Greg.
Yeah, thanks everyone. And as you can see, we're just about 10 minutes over our time limit. Let's just take a quick 5-minute break and be back at the top of the hour. So thanks so much to our community speakers and our conceptual framework speakers and opening speakers. And let's resume at the top of the hour. Thanks so much. And so I appreciate everyone's patience, and hopefully you're making it back to your computer and have had a chance to take a quick break. So I'd like to get started with our next session. And I'd like to invite all of our measurement presenters to turn on their cameras. So we have Dr. Lisa Bullock from George Washington University, Seth Kalishman from University of Connecticut, Jonathan Radina from Hunter College, Mark Katzenbuehler from Harvard, and Brian Dodge from Indiana University Bloomington. And then finally, James Hargreaves, London School, Hygiene and Tropical Medicine, Ann Stengel, Hero Solutions, and Virginia Bond, London School of Hygiene and Tropical Medicine. So I'm just going to take the prerogative and say thank you to our measurement folks. We'll have Lisa Bullock stay online. The measurement folks can turn off their cameras except Lisa. And Lisa, we'll go ahead and get started with your presentation.
Thank you. So what I'm going to do is talk about our 21 grant, in which what we're trying to do is develop measures of multi-level intersectional stigma for Black, gay, bisexual, and other men who have sex with men in Washington, D.C. and Jackson, Mississippi. Next slide, please. This is the title of our study, Developing and Validating New Measures of Multi-Level Intersectional Stigma, and our focus is on HIV prevention. We want to improve the HIV prevention continuum for this population. Next slide, please. So I want to show this slide because I think this signals why it's so important that we get this concept right. This is an example. This is an article not based on my research, but based on research that Dr. Catherine Quinn has done on intersectional stigma. And what's so wonderful about her work is that she really is sort of applying more of this sort of structural level intersectional stigma approach. But the photo to the right is an example of how our research is, gets the uptake of research. And so it's very important why we important that we have a strong and firm definition and conceptualization of what we're talking about when we're talking about intersectional stigma, and that is very much informed by community perspectives. Next slide, please. So our focus of our research is on the South, and specifically Jackson, Mississippi, and Washington, D.C. And the reason for the South, obviously, is because HIV has been particularly prevalent in the South, and with, not surprisingly, Black populations, and specific to the intersections that we're interested in, Black men who have sex with men accounting for the large, the disproportionate burden of HIV in the South. Next slide, please. So here is our investigative team. It includes Dr. Leandro Mena from University of Mississippi Medical Center and Dr. Paul Burns, also from Mississippi. That's sort of the Mississippi group. And in D.C., Shanika Hull, formerly of the GW School of Public Health. She now will be at Rutgers University in New Jersey. Dr. Tamara Taggart, the GW School of Public Health, and Dr. Ana Maria Del Rio Gonzalez, also of the Department of Psychology at GW. Next slide, please. And also our consultant is with great regret that I mention our consultant, Dr. Ron Simmons, who passed just a few weeks ago and who was instrumental to the study and also connecting us with people in Jackson, Mississippi. Next slide, please. Okay, so this is our framework, and we borrow this from Carmen Logi's work. And basically what we're trying to do is have a model of intersectional stigma that really, as I talked about in my earlier talk, encapsulates this notion of intersectional stigma at multiple levels, at the sort of individual level and or interpersonal level. And so we were very much interested in what are the barriers to HIV prevention for gay and bisexual men in terms of their interactions with healthcare providers, for example. We wanted to understand community-level stigma. So what happens, as an example, religious institutions, social media, how stigma is communicated at the community level, and then also structural. Very much interested in laws and policies that participants may know of or not, but nonetheless all sort of interplay to shape what happens in terms of HIV, access to HIV testing, and also PrEP use. Next slide, please. So here are the specific aims of our study. We wanted to develop quantitative measures, starting with qualitative interviews with Black, gay, bisexual, and other men who have sex with men in Jackson, Mississippi, and also Washington, D.C., and then to develop quantitative measures based on these interviews. We also want to develop sort of spatial visualizations, and this is where Tamara Taggart, being the member of our team, is just so fantastic, because we want to understand sort of where participants go and where they don't go. In the spaces they occupy, where they live, and what that might tell us about barriers and facilitators to HIV prevention. And then the second thing is to assess, after we've developed these measures, we want to assess the psychometrics of the measures at baseline in 6 months, and then we want to bring this all together, connect this in a typical mixed methods research approach. And I should say, surprise, surprise, our study has been quite interrupted by COVID-19, and so we're sort of at a pause in terms of recruiting participants for our study. Next slide, please. So this is a sort of a larger sort of mixed methods approach that we're using. Basically, as I said, we started off with literature and policy reviews. We really wanted to understand what's out there. What are some of existing intersectional stigma measures, and what are some of the ways that other researchers have measured structural aspects of stigma? So, for example, Mark Hudson-Buehler's work has been very instrumental to our work in trying to understand what stigma looks like at the policy and social and structural level. And then to develop these into quantitative measures. We're going to sort of combine these and synthesize the results. Next slide, please. So here's the eligibility criteria. You have, since our focus is HIV prevention, participants have to be HIV negative. We are looking for self-identified Black, gay, bisexual, and other men who have sex with men between the ages of 15 and 34. Initially, what we proposed to do was to do HIV testing to confirm that they were negative. Now we have to rely on clinician referrals in the last 3 months is one of the accommodations we've made because of COVID. Next slide, please. So what I want to do is just sort of talk you through very quickly what we're hoping to do. So we want to understand individual level stigma that's centered around the participants and to develop quantitative measures from what we learn in the qualitative interviews. Then we also want to understand sort of indices about stigma and what that looks like at the community level and then at the structural level. So we hope to develop measures that participants will be able to complete where they will tell us about their sort of intrapersonal, their internalized classism and racism and all of that, but also about interpersonal. We're very much interested in what happens in the interplay between individual participants and healthcare workers, for example. And then we want to know about, at the community level, what that looks like. And so asking people to tell us about, or, how heterosexuals are their communities, or about what they hear on social media about Black, gay, and other men who have sex with men. And then we want to know, for example, do they know, criminalization came up in the last panel, for example, are they aware of different laws sort of criminalizing HIV transmission, to understand how that can factor into intersectional stigma. And then we realize that there are a variety of things that people won't be able to report on, and this is the sort of the onus on us to learn how do we measure these different sort of structural manifestations of stigma at the community level. And so, for example, using the general social survey data of community level heterosexist attitudes, we want to know about anti-LGBT laws, for example, HIV exposure criminalization laws, barriers to PrEP. And then we also want to sort of map this all out. We want to understand, right, what this looks like spatially. What are the neighborhoods? So, for example, where are the HIV prevention clinics? Where are the places that somebody would go to be tested? Would that be in a neighborhood where Black men would not go, for example, because they know that they're much more likely to be sort of hyper-policed or followed or subject to stop and frisk? And so we really want to get a sort of spatial understanding of stigma. Next slide, please. And so I just want to show you about sort of what we're thinking about as we think about stigma in this sort of multi-level way, far bigger than just what individuals report about their own internalized stigma or what happens interpersonally. As I'm sure you all know, Mississippi recently voted to take the Confederacy flag off of the state flag, right? This is likely an example of sort of stigma in the air, sort of community level stigma about what it means to be Black in a place that is still flying the Confederate flag. And so this is something sort of a contextual factor that informs our work of stigma beyond just beyond individual level reports, but sort of community level stigma. Next slide, please. Also, relevant to our study or our focus on structure, go back one, please, is, previous slide, please, thank you, is this notion of state Medicaid expansion and its impact on access to PrEP. In D.C., where there are lots of different opportunities, expansion of Medicaid and opportunities to get PrEP versus a place like Mississippi that did not expand Medicaid, right? And so that tells us, we think, that might give us much more information about barriers to access to PrEP, something at the structural level, something at the policy level, rather than sort of individual internal, whether you've internalized stigma as a Black, gay, and bisexual man, really trying to understand these sort of structural factors that inform decisions people make around HIV prevention. Next slide, please. Similarly, HIV criminal laws, whether people know about them or not. And of course, we know that anytime we're talking criminalization in Black people, that Black people are disproportionately likely, Black and Latinx people, to face a harsher burden of any type of criminalization. So again, this is understanding structure or stigma through this lens. Next slide, please. This here is just sort of another example of how what we're talking about when we're trying to understand stigma at a multi-level, in a multi-level way. This is the Human Rights Campaign Fund. They give these sort of state equality indexes. And you can see that this is in 2019. DC got sort of high marks across all sorts of different laws, whether it's sort of youth laws or parental laws or marriage equality. Well, I mean, marriage equality is federal, but basically the point that there are so many more protections. And so one could hypothesize that stigma, at least at the sort of structural level, would be sort of experienced in a very different way for Black, gay, bisexual, and other men who have sex with men in DC compared with Jackson, Mississippi. Next slide, please. This is my final slide. Where you can see that Mississippi has not fared as well in terms of protections or equality for LGBT people. And so our project is really targeted to getting this sort of comprehensive look at how stigma at the individual level and the community level and also at the structural level, how these all sort of interlock and what this tells us about HIV prevention and also HIV prevention, what are the barriers, and also what are the facilitators. I'll end there. Thank you.
Thank you very much for that, Dr. Boleg. I'll take over from Greg now. If folks have, I see a really great question from Dr. Nealons. I'm wondering if folks have any clarifying questions. Otherwise, there will be a discussion immediately afterwards for about 15 minutes. And I think that the question there about teasing out structural elements versus individual perceptions and lived experiences is going to be a critical part of that discussion. If not, I'm going to thank Dr. Boleg, and we're going to move on to Dr. Kaufman. I think many of us know Dr. Kaufman, but he received his PhD in clinical community psychology from the University of South Carolina. He's a professor in the Department of Psychological Sciences at the University of Connecticut and director of the Southeast HIV/AIDS Research and Evaluation Project, the SHARE project, and also the editor of AIDS and Behavior and many other attributes. So we're really looking forward to his presentation on individual level elements around intersectionality as it relates to HIV. Thanks very much.
Thank you, Stephen. So I want to briefly talk to you today about a scale development project that we're doing as a part of this initiative. So I have several slides. I want to just go to click through to show you our approach to trying to measure intersectional stigma at the individual level. So next slide. So we're really working from the pretty, well-accepted approach to defining intersectional stigma conceptually that we've heard much about today. And I think what is sort of inspiring our work most is the idea that intersectional stigma is a unique entity in and of itself, that it is not just the sum of multiple stigmatized identities, that it is they come together to form a unique experience. Next slide. So intersectional stigma in HIV has been conceptualized in a few different ways. And so what we've been interested in is the intersection between stigmatized identities around race, around sexual orientation, sexual behavior, and the ascription to HIV as a disease itself. And so there's a long history in this literature of looking at HIV as sort of a layered or now really intersectional entity, in that it's kind of hard to disentangle HIV stigma as a disease, the contagion aspect of HIV, the parasite of HIV, from the other stigmatized identities that are often correlated with it. And so what we're really trying to do is do that sort of deconstruction. Next slide. So measures of intersectional stigma in the literature have varied. Sometimes what people will do is they'll ask questions in parallel. They'll ask about stigma and stigma experiences that can be ascribed to a particular aspect of an individual's identity, their race, or their sexual orientation. And then they'll have these separate measures and try somehow to combine them using multiple items that are difficult to bring together and create a composite, you'd say, of intersectionality. Next slide. Another approach has been to ask very specific items that are highly specified to stigmatized identities, like an individual's experience of stigma as they ascribe it to their race or their sexual orientation, their living with HIV, and have the person sort of conceptualize themselves that way. Well, the downside of that is they can't be disentangled. We really can't look at the subcomponents of those stigmatization. Next slide. So what we wanted to do was we wanted to work from the HIV stigma framework, really Valerie Earnshaw's approach, and in terms of conceptualizing HIV stigma. And we wanted to create a new approach to assessing intersectional stigma to establish the scale, reliability, and validity across a couple of studies. Next slide. So we embarked on really multiple steps to doing this. We had to generate and identify items, and the way that we did that was we looked towards the literature, both qualitative and quantitative studies of a variety of different stigmas relevant to multiple health conditions. Then we went through a process of selecting items in a large pool and then reducing that item pool. Then we conducted a few pilot studies to look at different response set properties. All of this work has been with Black men who have sex with men and trying to figure out the intersectionality of race and sexual orientation, and then also samples of people living with HIV to include HIV stigma. And then our final step is to look at these psychometric properties of this new approach. Next slide. So our item selection process led us to these subcomponents of enacted stigma. So we're looking first at enacted stigma. And what we've done is we've identified composites that can be grouped into pretty well recognized subcomponents of stigma, enacted stigma, the felt experience of stigma, interpersonal stigma that happens in relationships and exchange, discrimination experiences, and the stigma experiences specific to social media. So these, on this slide, you see a few, sample items. You see that we have 8 items in the felt and 10 items in the interpersonal, 8 in the discrimination, and 10 in the social media subcomponents. Their mean scores on a scale that goes from not experiencing at all, never, to 3, often experiencing, and the alpha coefficients for those subcomponent subscales of enacted stigma. Next slide. So this is what the measure looks like on phones that we deliver the assessment to our participants. This is all done in REDCap using programming that allows us to have skip patterns, so that if someone doesn't experience a stigma, they go on to the next item. So what our approach is we're asking participants to first tell us if they've had this experience of stigma, And then if they say that they have had it, whether rarely, occasionally, or often, they'll be asked additional questions of these 36 stigma experience enacted items. Next slide. So if they say that they occasionally experience this particular stigmatized experience, I have been treated unfairly in stores or restaurants, they'll be asked the next set of questions. Next slide. They'll be asked if they have had this experience, how upsetting it was to them, to get sort of a stress-related marker for it. And we use a slide bar that they can go from 0 to 100. So all these slide bar responses now for these next items relevant to that stigma experience are on a 0 to 100 scale. So we'll ask them, we are asking them how upsetting the experience was to them. Next item. Next slide, rather. And we're asking them to tell us what they believe is at the root of that experience. If they believe that that experience was primarily because they are Black African American, because they are a man who has had sex with men. In this study, what we've done is we've included the combined stigmatized identity of Black African American and because I'm a man who has sex with men. And this is the sort of traditional way of thinking about the combined stigmatized identity. And then we ask them if there are other reasons that, other than their race and their sexual orientation or that unique combined experience that they would say is the reason why they've been stigmatized with that specific item. Next one. So each of these responses then is on this 0 to 100 scale, demonstrated here as 0 to 10 for the sake of simplicity because the breadth of the slide. And we end up with these individual dimensions then. Next slide. And so for any given response, we're going to get an individual score. And in this study, what we're looking at is, in addition, we've got that combined because of my race and my sexual orientation response. So to be clear, everybody is asked all of these attribution slide bars for every item that they endorse having experienced of the 36 enacted stigma experiences. Next slide. And this is what the distribution looks like for that combined item. And you can see that it doesn't have great scale properties, but that is what it looks like. That's the frequency distribution for men saying that they've had that experience of being discriminated against in stores and restaurants because of their race and their sexual orientation. Next slide. And so we can do a few things already with this. We can compare because we've got the deconstructed responses. We can compare men's attributions for their stigma experiences on our 4 scales. You know, whether or not they attribute more of this to their race or their sexual orientation. And what we're seeing is a general trend towards ascribing their stigmatized experiences more to their race than their sexual orientation. Next slide. And when we compare their attribution to their race to their attribution to their combined race and sexual orientation, we see the same pattern, which doesn't really bode well for the combined item because it looks a lot like sexual orientation. Next slide. And when we look at the sexual orientation relevant to the combined item. So that's one thing we can do with the unit dimensions, but this is not really what we're after. Next slide. This is what we're after. So we're thinking that what we can do with these individual responses is consider them, to conceptualize them as orthogonal unit dimensions of an identity. And if we conceptualize these as unidimensional orthogonal dimensions, we can look at the intersection of them. And this is really what we're interested in doing, is trying to have a metric for intersectionality. Next slide. And so we can use actually geometry to calculate the intersectional score based on the scores that participants have for their race and their sexual orientation stigma responses to create a new composite. Next slide. And so it's just a simple geometry to be able to calculate from, in this case, a score of 7 on race and a score of 3 on sexual orientation, an intersectional stigma score of 7.6. Next slide. Next slide. Next slide. Because those slides were actually out of order. And so this is the distribution then for that new geometrically scale composite for the discrimination items. So what we did was we took the Pythagorean theorem, we took that formula for calculating intersectional score and applied it to each of the 8 items in the discrimination subscale, and then took the mean of that, and that's what you're looking at here. And I think you can see that its distributional properties look nicer statistically than that combined item, which was quite bimodal. Next slide. And so when we look at the correlation between our geometric score and the combined item for the discrimination scale, we're seeing correlations that are not 1, which is really good, and they're not low, which is really good. We're seeing them between 7 and 9, and so we're encouraged by that. Next slide. We're using the same approach for anticipated stigma. We've had a difficult time conceptualizing how to do this with internalized stigma, but I think we figured it out. So more to come on that later. Next slide. So in conclusion, I think we've developed a novel and a parsimonious approach to assessing intersectional stigma that can be applied across multiple stigmatized conditions and multiple stigmatized identities. What I like about this approach is that using a single pool of items, we can look at multiple different anything. We can look at, you could change HIV to diabetes. You could change race to social class. And the amount of data that we get from this scale is actually a bit mind-boggling, because from these three items with people living with HIV, race, sexual orientation, and HIV, we can get intersectional stigma scores for race and HIV, sexual orientation and HIV, and sexual orientation and race. And we can get the 3, because the Pythagorean theorem goes into 3 dimensions, we can get a intersectional stigma score for what it is like for my attributions for those stigma experiences to my race, my sexual orientation, and my HIV status as one entity. And so that's the project that we're doing. We're about done with study 1, which is our psychometric study. Right now, I can tell you that the scales look reliable, and we're getting some pretty good evidence that they've got some signals for validity. And so next will be our second validation study. And I think that's the last slide.
Thank you for that. That was a really interesting presentation that I look forward to studying in more detail. It's super interesting. I'm seeing really rich questions from Antigone Dempsey, from HRSA, and from Deepa Rao. These all seem very more discussion-oriented, so with that in mind, as was suggested by Judy Auerbach, I'll read those out as we get into the full discussion period. But for now, for the sake of time, I'm going to move on to introduce Dr. Jonathan Rendina, who is an assistant professor of psychology at Hunter College in the Graduate Center of the City University of New York. He received his MPH in biostatistics from Hunter's College in 2013 and a PhD from CUNY Graduate Center in 2014. And I think the key thing has been recipient of many awards, both from the NIH, but also importantly, the recipient of the 2018 Psychology and AIDS Emerging Leader Award by the American Psychological Association, and has really been mentoring and training the next generation, and really excited to hear him now move from first hearing about multi-level intersectional stigma, then to individual level, and now Dr. Rendina talking about event level. Thanks very much.
Great, thanks, Steph, and thanks to everyone who organized this conference. It's a real honor to be presenting here alongside all of these amazing speakers today. So what I'm going to be talking about today, I'm not going to focus specifically on my PRISM study, but I will talk a little bit about it. the notion of capturing stigma from an event level perspective is a little bit more controversial and, well, maybe not controversial, but it's more novel and people don't do it quite as often. And so I'm going to take a little bit more of a zoomed out perspective here today. I'm going to talk a little bit about when to consider event level data when doing intersectional stigma research, a tiny bit about prior work sort of validating the event level approach for stigma. I will then touch on our current PRISM study on event level measurement of intersectional stigma for diverse sexual minority men. And then I'm going to end with key considerations for ongoing work that I hope will help to inform the ongoing working groups that will be all broken into after this. Just to start out with, what is event level measurement of intersectional stigma? Event level measurement typically uses frequent or intensive sampling over time. So this can be daily diary research, ecological momentary assessment research, sometimes also called ambulatory assessment research. For the purposes today, I'm not going to differentiate between any of these different types of methods, but all of these would characterize the types of repeated intensive measurement that we think of when we think about event level measurement. And the goal here is to capture an experience repeatedly over time, typically as close as possible to as it's being experienced. And this has several benefits. It can reduce recall bias that is present when we do retrospective measurement. It allows you to capture within-person variation in state-like measures. So anything that you think changes within a person over time and context, this is a great method for capturing those and looking at those changes over time and context. And it allows you to look at micro-longitudinal effects, where your outcome of interest and at least one of your predictors of interest are event level and differ within people. So micro-longitudinal meaning that we're not looking at a person over a year, every 3 months, and how something at baseline might influence them at 6 months and 12 months, but rather we're looking at how something either in the early part of one day influences them later in that day, or how the effects of something happening on one day might influence them the next day. And so there are many reasons to consider event level measurement, but there are also plenty of circumstances where event level measurement is actually not ideal. And so event level measurement is really well suited if your outcome of interest changes across events. And this is particularly true for behaviors which are discrete and occur sort of in momentary experiences, for state-level cognitive and affective variables, as well as for biological and physiological markers that fluctuate within the context of a day or across a few days. And this can be things like heart rate, blood pressure, cortisol, any of these sort of factors that we can actually capture micro-longitudinal variability in. You should have at least one predictor that changes across events, so you would expect within-person variability in at least one of your predictors and not just in your outcome. You would expect, it's great if you're expecting complex associations in a micro-longitudinal fashion. So event level measurement is wonderful for if you are expecting any kind of reciprocal effects, if you expect to see spillover effects, so the way that I feel on one day is going to influence the way that I feel the next day, and sort of it's going to spill over time. Or if you're interested in incorporating any of the above plus individual level or other higher level predictors. So the thing that I love most about event level data is that you can't analyze event level data as single level. We always are going to be analyzing event level data within the context of a multi-level model. And so these types of event level data around intersectional stigma are particularly excellent for intersectional stigma because of its multi-level nature. We can take into account both individual level factors within these multi-level models, as well as structural and societal level factors within these individual level, within these multi-level models, depending on, you know, the number of people that we have and having sufficient variability at higher levels of analysis. These event level models are not well suited if your outcome of interest is at a higher level of measurement. So if you're looking at an individual level outcome, then event level measurement of stigma is not going to be super helpful because you're then going to have to aggregate those data up to another level of analysis to look at them. And so that kind of leads right into the next point, which is if you intend to aggregate the event level data, such as creating counts or averages over time, it may not be worth the extra effort of capturing event level data. You know, event level measurement is complex and it is also frustrating for the participants, and so it is important to keep in mind that there is always a cost and a benefit, and you should not just default to event level measurement unless it's actually going to have a strong benefit that outweighs the costs both methodologically and to the participants. And it's also not super well suited if you're doing something like capturing rare occurrences or really extreme types of events where even if you're measuring someone for a full month, you may never see that event occur in most people. That would not be a great use of event-level models. So I just want to stop there quickly and answer the question of why we would ever want event-level models when stigma is inherently social and structural. And I think I agree completely with people like Lisa Boleg, who is brilliant and rightly points our attention back to the structural level. I think the amazing thing about capturing event-level data in addition to those structural level data is that you're able to view stigma as a process. You're able to actually think about stigma as an outcome, and an outcome that actually isn't between people but within people. And you can look at each person and how they, their experiences change across context and across time, and how they respond to those different experiences. And so in that way, stigma becomes not just something you measure as a self-report, for example, but it can also actually become a process that you can study as an association. And so I'll talk a little bit more about that at the end of this. But that is one of the most exciting things that I think make event-level data a really interesting technique for intersectional stigma. I'm going to dive in now just to two quick studies that show some of the difficulties with capturing intersectional or stigma in general on an event-level basis, but also some of the benefits. So I'm starting right now with one study which we had 371 diverse, highly sexually active men who were sexual minority living in New York City. And we did 30 once-daily diaries that include daily affect and 2 items which we were piloting at the time, capturing daily experiences of sexual minority stress. Let me see if the little, so the little box is now coming up, which will draw your attention right to the point of this, which is the event level or daily measure of gay-related sexual minority stress. And what you can see here is that when we were looking at the association with day-level positive affect, day-level negative affect, and day-level anxious affect, we found a highly significant positive impact on negative impact and anxious impact, negative affect and anxious affect, and negative association with positive affect. And if you look down to the between-person level, you can see that we were able to disaggregate this event-level daily stigma measurement into within and between-person effects. And we did also, in the same model, observe similar effects at the between-person level. And so this shows that really we were seeing stigma operating at both levels. We were seeing between-person differences in stigma, and in this case specifically only about sexual minority identity, but we were also seeing these things change over context and across the course of different days within person. The same thing here is being shown now focused on the daily experience of HIV stigma. This is from a pilot study funded with a KO1 from NIDA, so thank you to NIDA for that. This is a sample of just 50 sexual minority men living with HIV in New York City. One of the nice things about event-level data is also that you capture so much data that you actually have pretty high power even with sample sizes like this of only 50. And in this study, we actually did twice daily, 21-day capturing of data. So this was an ecological momentary assessment study. And diving in again, here we actually tried to disentangle the experience of anticipated HIV stigma from internalized HIV stigma at both the within-person and the between-person level. And what we found actually that was interesting in this particular study was that internalized HIV stigma had significant effects at the within-person level across all of the affective outcomes that we captured except for fatigue, so anxious affect, depressed affect, anger, and emotion dysregulation. And we actually didn't necessarily see all of these effects come out at the between-person level. So we actually saw more within-person effects than we saw between-person effects, suggesting that a good deal of the variability that's actually impacting daily experiences of affect are occurring due to changes within people over the course of context and time. However, both of these studies had their difficulties, and I will say that one of the biggest difficulties is that for this study in particular, the ICC, the within-person variability in HIV stigma across days was actually very, the ICC was high, the within-person variability was low. So we had an ICC of about 0.8, meaning that about 80% of the variability was actually due to between-person differences and only about 20% to within-person differences. So this highlights one of the biggest challenges with capturing any type of stigma at the event level. And so we then went on to design this PRISM study to sort of address two of the big challenges that we have. One is that we don't have measures that are specifically designed for capturing event level experiences, and so we don't see a lot of within-person variability within the studies that have been conducted so far, and also that we just don't have measures of intersectional stigma, particularly within event level research more generally. And so I'm glad that I'm going after Lisa Boleg. We actually designed relatively similar studies to address sort of opposite ends of the spectrum when you think about the multi-level experiences of stigma. So ours is a three-phase study that started with systematic literature reviews and qualitative interviews, followed by multiple iterations of cognitive interviewing with the population of interest, and ending with what will be a daily diary quantitative validation study. And this is a study that is looking at the experiences of intersectional stigma among Black, Latino, and white sexual minority men. And we're recruiting all of these men from an existing cohort study that we have of HIV-negative men across the United States. The aims were to generate and iteratively enhance a pool of items using available literature, expert input, and feedback from young sexual minority men. This is also among young Black, Latino, and white sexual minority men, so 18 to 29. The items are designed to be culturally congruent, well understood, use appropriate response options for daily measurement, and represent the range of relevant experiences for YSMM in daily life, and then to test the psychometric properties and validate these items for future use. I'm going to focus in on the qualitative interview phase that we started the study with.
Jonathan,
this will be.
Can you try and wrap up in the next minute or two? Sorry. Thanks.
Yep, this is one of my last slides. So focusing in on the qualitative interviews, we identified some major themes. One of those themes has been well discussed today. Intersectional identities are inextricable, and in some cases, for some people, stigma experiences may be attributed to a specific identity, but this is overly simplistic. Intersectional identities provide opportunities for resilience and resistance, and so we need to be capturing the positive experiences as well. Identity salience is context dependent, but also space and place are critical, and so we need to be capturing how people are interacting with the spaces that they're in on a daily basis, and that we need to focus on process and not content. So going back to what I said in the beginning, intersectional stigma in particular should take into account not how stigma looks, but also how it becomes a part of a person's daily narrative. So this is my final slide, key considerations for future intersectional stigma research that's using event level measurement. Avoid focusing on extreme experiences. You don't see them often in event level measurement. Avoid trying to tease apart identities or isolating one driving factor. People don't see themselves in that way. They view themselves as a whole. Quantifying stigma should go beyond tallying up frequency and the range of experiences. We should add a focus on both positive and negative responses to stigma. Consider not just social interactions, but also relations to space and place. A general sense of safety and belonging within spaces is an experience of privilege that not everybody has. Considering indirect capture of intersectional stigma by looking at the associations among variables and not necessarily the variables themselves. I have to say thank you to a ton of amazing people, my study team, Dr. Ali Talan, Dr. Devin English, or Carly, and the entire PRISM study team, with special thanks to our consultants, Dr. Viraj Patel and Lisa Boleg, and Greg Greenwood for organizing this and helping to fund this initiative.
Great. That was a really powerful discussion. I feel terrible hurrying it along. It is incredibly rich. I'm going to, in the spare time, there's a lot of really great questions that have been posed. I want to try to make time for that, so I'm just going to move right to Dr. Hassenbuehler's presentation. To introduce both Dr. Hassenbuehler, who is the Associate Professor of Social Science and Department of Psychology at Harvard, and was previously at Columbia, where he was a Robert Wood Johnson Foundation Health and Society Scholar. And I will also introduce Dr. Brian Dodge, who will join us for the Q&A and is co-presenting or with Dr. Hassenbuehler, who's a professor in the Department of Applied Health Science at the Center for Sexual Health Promotion at Indiana University School of Public Health in Bloomington, and has co-authored a tremendous number of publications. Thanks.
Thanks to Dr. Greenwood and the organizers for inviting me to be a part of this great conversation. So I'm going to briefly present some work that my colleagues and collaborators and I have been doing in the area of structural stigma and talk about how that can be applied to research on intersectionality. So has been mentioned several times today, stigma has been conceptualized in the literature as a multi-level construct ranging from individual to structural levels. So really briefly, it's just going up in the wrong way. Individual forms of stigma refer to the psychological processes through which stigmatized individuals both perceive and react to stigma. And there are numerous individual psychological processes that have been identified that have already been mentioned today, things like self-stigma and concealment. In contrast, interpersonal forms of stigma refer to interactional processes that occur between the stigmatized and the non-stigmatized. So these can include really overt events like bias-based hate crimes, as well as more subtle interactional processes like microaggressions. And the vast majority of research on stigma has really existed at these two levels of analysis. And that work has been really important because it's documented many of the ways in which stigma operates to produce disadvantage. But at the same time, this work has been criticized for overlooking broader structural forms of stigma, which my colleagues and I have defined as societal level conditions, cultural norms, and institutional policies and practices that constrain the lives of the stigmatized. And this lack of research on structural stigma relative to stigma at other levels of analysis has been called by my colleague Bruce Link a dramatic shortcoming in the literature on stigma, as the processes involved are likely major contributors to unequal outcomes. And one of the reasons for this lack of research on structural stigma is that until recently, the field simply hadn't been measuring it. So this is demonstrated in the paper that Bruce Link and his colleagues did that reviewed measures of mental illness stigma. And it found that only two studies, less than 2%, had actually measured structural forms of stigma. And while that paper was focused specifically on mental illness stigma, the same can really be said for research on other stigmatized statuses and characteristics. So given this lack of structural stigma measures, the field really had to go about developing measures that could reliably capture this construct. And there are a couple of different measures that researchers have begun to use. So I'm going to briefly mention three that have received the most attention. I'll talk briefly about some of the advantages and disadvantages of each type, and then provide just one illustrative example of how research has used these different approaches to study how structural stigma influences HIV outcomes, given the focus of the conference today. So the first measurement approach is social policies that promulgate stigma. And researchers have used two different approaches here. One is to examine single policies, and the other is to examine composite measures of multiple different policies. One advantage of this measurement approach is that they rely on objective data sources to code the social policies, providing clear evidence of structural stigma. But they also have limitations. So this includes the fact that policies may not always capture the unwritten customs and procedures that undergird more informal practices that can constitute structural stigma. And in addition, sometimes these policies lag variation and so represent a ubiquitous exposure. And without variation, there's of course no statistical power to detect an effect, even if we think that these forms of structural stigma may be relevant for health. So I'll just really briefly mention an example of this approach from a paper that my colleagues and I recently published. So here in this example, we combined 11 different state-level policies related to sexual orientation over a 15-year period and derived 3 different latent groups that we used or that we defined based on growth mixture modeling. So as you can see here on the left-hand side, states fell out into 3 different categories. One was those that consistently had low policy support for sexual minorities, shown in green here. States with consistently high policy support for sexual minorities, shown in blue. And finally, states with increasing trajectories of policy support for sexual minorities, shown in red. And this figure on the right shows a map of U.S. states grouped by these 3 different policy classes. We then linked this policy data to anonymized longitudinal HIV/AIDS surveillance data from the CDC, which was aggregated to the MSA level. So here are the results for our study. The outcomes are shown here on the top. And you can see here that we found a dose-response relationship between the state policy classes in each of the 4 HIV outcomes, such that the lowest risk of HIV outcomes were found in MSAs in states that had the highest level of policy support for sexual minorities. And in addition, we used population attributable fractions, and we found that about a quarter of HIV diagnoses, about 21% of late diagnoses, and about 10% of AIDS-related deaths among MSM were attributable to the state policy climate. So a second measurement approach has moved from policies to consider aggregated social norms. So these represent an important indicator of structural stigma because social attitudes not only reflect but also shape many of the other components of structural stigma, such as policy regimes that we just talked about. So in this approach, researchers aggregate individual responses of people's attitudes up to the community level, which is defined at various geographic scales, such as U.S. counties. And this enables researchers to compare the level of structural stigma across these different geographic scales. So there are two types of these attitudinal measures. One is self-reported and the other is non-self-reported. So one of the major advantages of these explicit measures is that they avoid same-source bias. And that's because the exposure and the outcome are measured via two different data sources. But these also have limitations. One of them, of course, is social desirability bias. So people are less likely to report negative attitudes for socially sensitive topics like stereotyping and prejudice, which can potentially underestimate the level of structural stigma when using these measurement approaches. So given that limitation, researchers have started to develop new measurement approaches that don't rely on these explicit self-reported attitudes. And these include the use of implicit measures like IAT scores or behavioral measures like Google searches, which are then aggregated to community levels. They have the main advantage of overcoming some of the social desirability biases that are present with explicit measures. But there are also limitations to these measures as well, including some questions that researchers have raised regarding some of the psychometric properties of these measures, including their construct validity. So let me just present briefly one example of a study that used this explicit measure approach of aggregated community norms. So this is a great study by Alicia Reed and her colleagues, and in this study, what they did is they reanalyzed a meta-analysis of individual-level psychological interventions to reduce HIV risk behaviors among African Americans. And they capitalized on the fact that these interventions had been done across the U.S. in communities that differed in terms of the level of structural stigma related to race, which they measured by aggregating whites' explicit attitudes towards blacks in the communities where these interventions were done. And so here are the results. Here on the y-axis are the mean effect sizes for these HIV interventions, and on the x-axis are white attitudes towards African Americans in those communities where the interventions were done. So this is a feelings thermometer, so it's reverse coded. So higher scores indicate lower prejudice. So you can see here on the right-hand side, in the lowest prejudice communities, the effect sizes are really robust and in fact persisted over time. But in contrast, on the left-hand side here, in the highest prejudice communities, you can see that these interventions were completely ineffective in the highest prejudice communities. So these findings suggest that structural stigma related to race may undermine the efficacy of individual-level HIV interventions among African Americans. So, so far I've discussed measures of individual indicators of structural stigma, either in the form of social policies or aggregated community norms. But in a third measurement approach has been the use of composite measures of structural stigma. And this approach here, as the name suggests, is to combine multiple different measures of structural stigma, such as laws, policies, and social attitudes. And there are a couple different reasons for the use of these composite measures. The first is that different dimensions of structural stigma are highly correlated, suggesting that they may tap into a latent construct of structural stigma. Secondly, by combining these indicators, it may improve construct validity because they acknowledge that there are many different components of structural stigma. And then third, composite measures tap into shared variance and as a consequence minimize unique variance, that is unmeasured variables that may reflect other constructs, and in turn can reduce measurement error. But despite the many advantages of these composite measures, they're of course not appropriate for every research question. And in particular, they may not be appropriate for research questions that seek to evaluate which individual component of structural stigma is most robustly related to health, which of course can have important policy and intervention implications. And so there's sometimes a tension between the use of composite measures, which have these methodological advantages for research, yet may be less relevant for interventions and policies. So let me end by briefly mentioning what I think are some of the implications of structural stigma theory and evidence for research on intersectionality. Well, I think that we need to do a better job of integrating this work on structural stigma with intersectional frameworks. And let me say just a little bit about what I mean by that. So as has already been mentioned, most quantitative research currently tests intersectional hypotheses by examining interactions between demographic characteristics like race, sex, sexual orientation, SES, and so on. But intersectionality theory and frameworks are really about multiple intersecting systems of social oppression. And so we should be testing those frameworks by actually measuring those systems of social oppression and examining their interactions. And structural stigma provides one way to potentially do that. So in just one example of this approach, John Pachinkis and his colleagues created measures of structural stigma related to sexual orientation and to immigration status using composite measures of structural stigma like the ones that I mentioned in the previous slide. And they then examined interactions between these. Yeah,
wrap up in 1 minute, please.
Yeah, I just have one more slide after this. They looked at interactions between these two forms of structural stigma and showed that they predicted HIV risk outcomes among migrant MSM. So this provides one potential framework for how researchers can go about doing this work. So to conclude, the good news is that researchers have triangulated evidence for the negative health consequences of structural stigma across multiple measures, methods, outcomes, and stigmatized groups. But this work has yet to be really fully integrated with research on intersectionality despite the clear relevance of the structural approach to intersectional frameworks. And so I think in order to move this field forward, we need to address some of the challenges to conducting this work, and that includes two things. The first is obtaining necessary data across multiple different components of structural stigma over time and at the appropriate geographic level that corresponds with health data sets. And then secondly, the corollary of that is that we have to address the lack of data structures that have geographic identifiers. Most existing data sets either don't make geographic identifiers available or they place significant restrictions on how the data can be used, which is a significant methodological hurdle to doing this work. So I'll end there and sorry for going just a little bit over.
No, thank you so much. And we'll get to Dr. Dodge during the Q&A. So I can't do justice to Drs. Hargreaves, Stengel, and Bond other than say that they are leaders in the field and will be speaking to us about HP 10071. Dr. Hargreaves has committed to 10 minutes, so we can have 10 minutes for a Q&A. Thanks very much.
Can you hear me okay?
Yeah, perfect.
Now can you hear? Okay, great. All right. Thanks very much, Steph. I'm going to talk about the HPT 10071 pop-up ancillary study. I need to quickly acknowledge NIAID, who sponsored the study, and particularly NIMH, who funded the stigma work within this study, which is a completed study and not one entirely about intersectional stigma. This slide represents the people who conducted the pop-out trial, and always important to give thanks to the many research participants who took part in this study. Nearly 1 million people were involved in the community. Pop-Up was a cluster randomized trial, by some measures one of the largest HIV prevention trials ever undertaken. It happened in South Africa and in Zambia, and it enrolled 21 communities. It reported in the New England Journal of Medicine last year, so I'm not going to talk about the results. But central to Pop-Up was an intervention based on community HIV care providers delivering door-to-door annual HIV testing and a range of other referral services. And the trial measured HIV incidence amongst a very large cohort of over 40,000 HIV-negative adults in these 21 communities and viral suppression amongst people living with HIV. What Greg asked me to talk about was three things: how our team developed the stigma measures that we used within this work, a quick overview of the actual measures, and then to say something about running a study like this within the context of a very large cluster randomized trial. So this slide lists some of the key principles that we used when we developed the measures that we used in Pop-Up. The first, which I'm going to talk about, a few people have mentioned this idea, but I think we really went to town with this notion of a parallel approach, and by that we meant two things. We asked different groups of people about their perspectives on aspects of stigma using similar wording. And among health workers who we had additional resources from NIMH to do a more detailed study, we asked them about different groups using the same wording. And I'll give you examples of both of those things in a minute.
Where possible, we wanted to build on existing items, so we did desk review, as some of you are planning for your upcoming studies. We had to balance the breadth of things that we wanted to cover, including drivers and manifestations across these multiple domains of stigma, and depth, and you'll see a little bit about how we tried to do that. We had fairly clear hypotheses that we wanted to get at, and so our approach to grouping items was driven to a great extent by theory, as well as obviously data-driven approaches. We had a mixed method study, and we in particular wanted to leverage the power of the trial throughout. Our idea was around trying to collect data from each of these different groups mentioned here, from or about, and particularly about the interpersonal stigma that you've heard about already. So we collect data from the community, from people living with HIV, health workers, and from key populations. And you can see on the right-hand side of the slide some of the domains we were interested in. We, for example, collect data from community members on their fear and judgment towards people living with HIV, from health workers about their perceptions of levels of stigma in communities and in health settings, levels of anticipation of stigma amongst various groups to do with both accessing services and stigmatization because of identities, and then, of course, in particular, experienced stigma reported by people living with HIV, as well as internalized stigma. So that was our overarching approach. Let me share with you just a feel for some of the measures. Amongst people living with HIV, here's a selection of the, we had a very large sample, around 4,000 people who we followed over 4 years. This is an example of some of the questions we asked about experienced stigma in healthcare settings, and you can see that phrase about being talked badly about because of my HIV status. That idea, that phrase also appears in the questions that we asked of the around 4,000 people who were not living with HIV who we interviewed in communities over these 3 to 4 years. And you'll see on this slide also examples of the sorts of things that people were asked about, whether they've been verbally insulted, physically assaulted, etc. And then you can't see this slide because it's very small, at least if you have the same screen as me, but what this shows is that the domains that we captured were internalized stigma at the top, experience of stigma in the community in the middle, and then experience of stigma in the healthcare setting. And this is all data collected from people living with HIV. To go alongside that, we talked to these members of the community. Then we asked about their perceptions of levels of stigma in the community, including these same memes such as talking badly about and verbally insulting. We asked them also about their own levels of fear and judgment towards people living with HIV, their perceptions of level of stigma in the community and in healthcare settings. And then finally, we had an opportunity to ask many questions of health workers. And here, again, you can see this idea of parallel measures coming across again. Here we asked about their perceptions of co-workers' behavior, including these same memes across these questions. And amongst this group, again, we have this idea of collecting data on fear and judgment, perceptions of stigma in community and in the health setting. And this idea of parallel ran throughout this opportunity to collect data from all of these groups. The final way in which we did parallel measurement was, as I mentioned, we asked health workers using one of the other memes, which was to do with shame. We asked them about feelings of shame, but not only about people living with HIV who might visit their services, but other stigmatized groups in their communities. And from this you could get a sense, again, of the same concept running across opinions about different groups from the perspective of health workers. Let me end with the third thing that Greg asked me to talk about, which was about integrating our work within the Pop Art trial. This was a formal ancillary study and working group within this, as I say, enormous cluster randomized trial. Much of our job was to make visible and continually shout about the importance of stigma and other social determinants of health within the context of a trial like this. We had some additional funds, as I said, from NIMH. And the work was very mixed method. There was a social science group nested within the main trial led by Ginny, who you'll meet in a second, and we worked very closely with them. And I was trying to think of 2 key things that served us well in having our voices heard in this very large research community. And I think the 2 I landed on were, one was that we had 3 very clear, simple hypotheses, which we put up at every opportunity that we spoke to this very large and multidisciplinary group, and I'll show you those in a second. And secondly, that throughout everything that we did, we used a mixed methods approach and triangulated across from quantitative to qualitative data, and that strengthened our arguments within the trial. Here are those 3 hypotheses that I put up every 6 months in front of this large group of people all of the time. One hypothesis was that the
implementation of the pop-up universal test and treat intervention would change levels of stigma. A second was that HIV stigma would undermine the effectiveness of this approach. And the third was that over the course of the trial, as UTT was delivered, the forms that HIV stigma would take may change. And as I say, these three hypotheses or questions guided us, and they served us very well in communicating with our colleagues. And our final thing is about triangulation. These are some of our findings. I haven't really got any time to talk to you about findings, but one of the things that we discovered in the quantitative data were very slow but significant over time declines in HIV stigma. This is our measure of any stigma reported by people living with HIV. And we were able to set that against some of the narratives we got from people talking in communities. And here you can see two opposing narratives. The first is about the normalization of HIV testing. And it's a very mundane quote talking about how somebody came to their house and they explained they were going to test people, and they asked if they could test me, and they could. And that's juxtaposed with this opposing force of still towards the end of the trial, oh geez, I told myself if I must have it, then I'll throw myself under a train. I won't be able to live with such an illness. And this quote speaks to the continued pressure felt by people living with HIV around stigma. And it was these combination of forces working in different directions, which I think triangulate well with our finding of a slow decline over the course of the trial in levels of stigma. Steph, I think I got close, at least to the 9 or 10 minutes. Thanks very much for listening, and I'm happy to answer any questions.
That was great. So I'm going to ask everybody to put their cameras back on for the Q&A, and I'm going to start with Dr. Dodge to share some perspectives really about like structural stigma within and among sexual and gender minorities, and really the results of the work that you've done together with Dr. Hatzenbuehler. Thanks.
Sure, Stefan, thanks so much, and I'll try to keep this brief. As you know, this is focused on HIV, but it intersects undoubtedly with sexual and gender minority communities. And after Mark's stellar summary of the concept of structural stigma in terms of sexual orientation and sexual orientation in particular, I don't think we're quite there yet with gender identity. Many of the measures have been based on aspects like same-sex relationships or marriage equality, but there haven't been any that have been specific to bisexual, queer, and other non-monosexual communities or to transgender communities, which overlaps because the majority of transgender and non-binary people identify as bisexual or another identity. So Mark, in the beginning of our study, our cohort of 500 gay and bisexual men, a probability sample, sort of threw down the gauntlet and said, what would structural stigma look like among bisexual communities? And I'm still struggling with that because, again, the majority of bisexual individuals partner with people of other genders. When someone mentions plural marriage, I go, oy vey, I'm getting spielkiss, because, you know, bisexual people can also be monogamous. It's not just an issue for bisexual people. But I do think that it's important to start thinking about this, particularly in terms of gender identity and gender minorities. It would be great if we had state or federal level data for gender minority-related issues. But I do think with bisexuality in particular, within the structures of the LGBTQ plus community, which is really LG community in many ways, I think we can start to do some structural work there, because that's where in national probability samples of Americans, just in terms of attitudes toward bisexual people, the lesbian and gay people in particular are in need of intervention.
Thanks for that. Can you hear me? Oh my God.
Yes, we can.
Yes.
Oh yeah. Oh, okay, great. Sorry about that. Okay, I have a question here from Antigone Dempsey, and I think this really applies to everybody. And the question is, it's interesting to think about HIV stigma because I don't think you can separate HIV stigma from where it originated, which is that certain populations and certain communities are designated as having HIV. And so can folks maybe talk, I think this is very much at the heart of intersectionality, and I think maybe lots of folks here are really well suited to take on that question, but does somebody want to take that on?
Steph, I can have a quick go at it and say two things. One, I guess, is that I agree that it's hard to disentangle those two things. I was going to say two things. One is that I agree it's very hard to pull apart those things. In the settings where I work in Southern Africa, it does, though, there is, I think, growing sense that some degree of normalization around HIV and particularly accessing HIV testing services has happened. And increasingly those longer standing prejudices that were there before HIV came, but that were heightened by HIV and where stereotyping occurs, those are residual and stay around. And whereas people, the way that people talk about HIV is changing.
Okay, Brian, I'm not sure if you can hear us, but I'm going to have there's a question here for Dr. Bowleg, and I think it actually speaks to some of the elements that we heard throughout, but really about the importance of measuring both sort of the structural determinants as well as lived experiences, and it leads nicely into another question from Deepa Rao. But really, if you could maybe tease apart from your work a little bit about the teasing apart structural elements and then the lived experiences among, for example, people and their perceptions, views, and mental health effects of lives.
Well, so if I think I understand this question, so the lived experience is critically important for centering, as I talked about that as a core concept earlier, particularly when researchers are not members of these groups. It's very important to understand from the inside of, what it means to be a member of one of these groups, and so that's really important. But I guess one of the things that I do want to highlight is that as important as it is to forefront lived experience, it is also just as important, the sort of burden is on researchers to be very sort of cognizant of the structural reality.
Mark, do you want to take that because my reception is really spotty?
Otherwise, we run the risk of if a person didn't report this experience on a self-reported measure, the person didn't say that they were stigmatized, didn't say that they personally experienced discrimination, that it doesn't exist. And that's really problematic. We understand that there are sort of systemic and historic and structural forces that are at play regardless of whether or not people mention them or not. And so this is sort of like one of these traps with intersectionality that we can run into. We're like, oh, well, people they didn't talk about the racism, they only talked about the heterosexism, and so then maybe it doesn't exist. And so that's one response to that. If I may, I wanted to say something about the previous question about, separating HIV stigma from where it originated. We understand that when the stigma is in a group that has been historically oppressed, that we can expect that the stigma would be worse. A good example of this is the shifting tide on the opioid crisis when it happened in the U.S. and it was, happened in white people. All of a sudden we saw this very sort of compassionate response that had never sort of accompanied substance use when it was in black people. And we know that there are all sorts of structural factors that ensured that black people who were using drugs would be criminalized and locked up. And so it is very important that where the stigma originates or is perceived as originating sort of informs how we treat them in terms of interventions, laws, research, and so forth.
So just to say, there's a question here from Deepa Rao that I think maybe Lisa and others could really speak to, because I think it builds on the comment that was just made about lived experiences. But whether, just maybe speaking to the importance of NIH adding lived experience as one of the review criteria for these grants and really ensuring that, people with experiences, these lived experiences, including Black and Indigenous and people of color PIs work really being brought to the fore. So I don't know if folks want to speak to that, but I think it's, if obviously you're not the NIH, but just if folks want to share some perspectives on those elements.
I'll go. I think it's critically important, right? But I also think that there's a further step, and that is that community-based organizations and organizations are, You know, they have the ties to the community, they have the commitment, they're often doing the work, but with very little resources. There needs to be some way to sort of share the power, whether it's sort of sharing the resources so that they can continue to do their work. And so there's really a need, as I see it, for sort of really community academic partnerships that are really grounded in mutual respect, you know, grounded in sort of shared power, such as the academic researchers. We bring our academic training and all of that, but the recognizing and valuing the assets and knowledge and indigenous knowledge in communities. And there needs to be a way that, you know, so that it's not just the researchers getting the funds or going to communities for help us, you know, collect data. There really needs to be some type of structural shifting, I think, beyond just celebrating or acknowledging lived experience.
That's really helpful. It pains me. I had gone through each of the presentations and prepared questions. We have like a dozen unanswered questions for this group, and we are perfectly out of time. And so I really want to thank all of the speakers. I think a lot of the questions that are here, some of them are technical, including ones for Dr. Kalikman and Dr. Hatzenbuehler and Dr. Medina, in fact, everybody, about scale development, about some of the analytic approaches, and I think that's at the heart of these measurement challenges. These are incredibly complex elements, and I think we're all working on appropriate measurement strategies, and I think we heard some really rich examples of that today. I think this is where this is going to close, which is painful for the measurement section for those of us who work, but obviously we are going to be continuing this work throughout the summer, and I'm appreciative to all of our speakers and want to give, I guess, a virtual round of applause as they are for that. So thanks very much.
Great. Thank you, Steph. And with that, let's take a 5-minute break. We'll be back in 5 minutes and start with the intervention.
Welcome back, everybody. It is my pleasure to get the next panel started by introducing the panel moderator. Dr. Janet Turin is a professor in the Department of Healthcare Organization and Policy at the University of Alabama at Birmingham School of Public Health. She's the director of the UAB Sparkman Center for Global Health and co-director of the Behavioral and Community Sciences Core at the UAB Center for AIDS Research, the CFAR. And she is serving and as the moderator for our next panel on interventions. Dr. Turin?
Thank you very much, Paul. I hope you can hear me.
Yes.
Yes, great. Okay, so yeah, I'm excited to be moderating this panel because it's great to see that interventions are actually being started to be developed that are really attempting to address a variety of combinations of intersectional stigma. And really thoughtfully, I think you'll see in this panel some very thoughtfully developed interventions, including, interventions that deal with either community or healthcare settings, interventions that address providers and also the people that are actually experiencing intersectional stigma. You'll also see examples in this panel from different settings across the globe, including China, US, Ghana, and Brazil. And the stigmas that are being addressed include HIV, sexual orientation, gender nonconformity, sex work, and substance use. So I think this will all give us some great ideas and models to start building on. So the presenters in this panel include Dr. Kumi Smith of the University of Minnesota, along with her colleague Sean Sylvia of UNC. The next presentation is going to be from Victoria Fry of CUNY School of Medicine. That's going to be followed by a joint presentation by LaRon Nelson of Yale and Laura Neidlade of RTI, followed by a presentation by Laura Bogart of RAND, and then wrapping up from UCSF, Dr. Jay Sevelis and Dr. Sherry Littman. So with no further ado, let's go ahead with Kumi Smith.
Great, thank you for this introduction and for a chance to speak. I'm hoping the slides will load in a second. I'm Kumi Smith, and I'm presenting on behalf of myself. I'm at the University of Minnesota. I used to be at the University of North Carolina, where my co-PI, Sean, is. We are a epidemiology and health economics co-PI team. Our team works on healthcare stigma, so that's enacted interpersonal stigma in which healthcare providers exhibit discriminatory attitudes and behaviors towards patients of marginalized identities. Many stigma reduction trainings for doctors exist, and they often address more than just HIV stigma out of the awareness that the interlocking nature of intersectional stigma means that our failure to address all of its forms can undermine our ability to address even one of them. But the very interlocking nature of intersectional stigma can hinder our ability to assess whether and how our interventions are impacting it. To address this, our team went back to sort of the basics of interpersonal stigma, where you usually have roughly 2 people. And we reflected on the fact that every instance of enacted stigma involves an enactor and a victim. In our case of healthcare stigma, the enactor is often the healthcare provider, the victim is often the patient. What we understand to date about enacted stigma unfolding in clinical settings tends to come from one of these 2 sources, the patient or the provider. If we ask the doctors, the so-called enactors, to tell us what's happening in their clinical encounters, they do have high incentives to not tell us the entire truth. This is social desirability bias. If we ask patients to report on the stigma they experience, we expect less bias, but it can be challenging for victims to pinpoint the exact reasons that someone may be treating them poorly, especially if they are a very complicated clinical case. One potential idea that we have is that we could introduce a neutral third party to observe, witness, and report on the enacted stigma taking place in these clinical encounters. For example, we could have a study team member who shadows doctors and observes what happens as they carry out their clinical duties. But we know from experience that clinicians under observation will alter their behaviors, a phenomenon known as the Hawthorne effect. Our solution to this is to therefore supplant the patient with the third-party observer, who then can assume the role of being both the so-called potential victim and the observer at once. This can be achieved with a technique we call the unannounced standardized patient visit. This borrows from a long tradition in medical education of using standardized patients, that is, trained actors who specialize in role play and constructive feedback with medical trainees. As depicted in this picture, this type of training usually happens in settings where all parties are aware of their assigned roles. And the standardized patients, or we call them SPs, are seen as a member of the training team. Our project takes this concept a step further by having our SPs conduct unannounced visits, in our case, to sexually transmitted disease clinics of interest. Our SPs are members of the local community of men who have sex with men, who we recruit and train to present a standardized case at each visit and then report back to us what happened. Visits are only conducted with providers who consent to it in advance. This is very important and often missed, so I will say it again. Visits are only conducted with providers who consent to it in advance. However, providers are not told when the visit will happen. Our hope is, of course, that they will not realize that the patient in front of them might be one of our SPs. Our SPs undergo rigorous training in advance to ensure that the cases that they present are highly standardized and to ensure they can accurately and objectively observe provider behaviors during the visit. Details of what happens in the visit are recorded immediately following it by a team member who administers a healthcare checklist to the SP. This work is taking place in STD clinics in Guangzhou, China. China is where Sean and I have worked for most of our careers. It should be no surprise that our work has also been paused by the COVID pandemic. Regarding the intersectional aspect of our work, we randomly vary the HIV status and sexual orientation that our SPs present across visits. This allows us to compare what care looks like across multiple stigmatized identities. This table shows how we can compare what happens when an SP presents as either a straight man living with HIV, as a man who has sex with men who does not have HIV, someone with both identities, and someone with neither. The value in each of these cells will eventually represent a score that reflects the average quality of care received in every instance when an SP presented with that specific profile. Comparing each of these three identities with the referent case, in our case, a straight man without HIV, is our approach to separately quantifying HIV stigma, homophobia, and their intersection. This may help us test that common hypothesis of whether the stigma experienced for multiple identities is greater than the sum of its parts. Our ultimate goal is to use what we hope and expect will be objective and specific observations of the patient-provider encounter to inform the design of a targeted training that addresses the real problems that we're actually observing in the clinics that we're working with. We are planning to do so by formally sharing back the results with two separate community advisory boards, one of providers and one of MSM. Doing so, we hope, lets us leverage valuable input from those closest to the problem and to help us reconsider the drivers of stigma that they're perceiving to be happening in their peer group, and may likely establish a way to help the community help itself. We have just two quick examples of how we think insights gleaned from SP visits might be able to fuel creative new ideas for ways that we can help providers provide more patient-centered care for these stigmatized populations. During one of our pilot SP visits, an SP reported back to us that he visited with a doctor who had very satisfactory clinical behaviors. However, he had a colleague who exhibited really highly stigmatizing attitudes. In this case, it was a colleague who warned other patients in the waiting room not to enter the exam room because someone with HIV had just been in there. This finding might be the type of thing that would suggest that, for example, maybe our training should incorporate a component to empower doctors and give them tools to navigate difficult conversations about stigma with their colleagues. A second example is another SP who reported that a doctor he saw actually thanked him for sharing his HIV status and proceeded to provide a high standard of care. This was not the norm, but was something that we did observe. This finding might suggest that we could think about the positive behaviors that are already taking place in the community and help us think about shifting our role as researchers from one of instruction rather towards facilitating more peer-to-peer training among doctors themselves. We're hoping, obviously, for more insights as our study progresses. And we're very happy to take questions during the Q&A. Thank you. Thank you very much, Dr. Smith. That was a really nice and very concise explanation of your work. So now we'll move on to Dr. Victoria Fry from King School of Medicine to tell us about their work in the U.S. We can't hear you, Dr. Fry.
And you may be muted.
Can you hear me now? Yes.
Yes, we can.
Okay, great. Okay, so community level interventions rest between structural interventions such as state level policies and peer or network level interventions. They often focus on shifting attitudinal or social norms like HIV stigma or behavioral norms like HIV testing at the community as opposed to the individual level. And while they may be included in what Parker and Aggleton call the broader social, cultural, political, and economic forces that structure stigma, they are not structural interventions per se, but as Mark Hudson-Buehler pointed out, they can influence structures such as policy. However, when viewed or implemented through a deficit lens, they do run the risk of shifting a blame the individual approach to a blame the community one, when in fact the community has been influenced by larger structural, political, economic forces. Evaluations of community-level interventions are extremely challenging. I'm going to talk today about a project called Change. Our research team pictured here evaluated a community-level intervention to prevent HIV stigma and homophobia in a high HIV prevalence in neighborhood in New York City with funding from NIMH, thank you NIMH, called Change, Challenge HIV Stigma and Homophobia and Gain Empowerment. It was a community academic partnership between gay men of African descent, Brooklyn Men Connect, and researchers at the New York Blood Center. Pictured here are key team members, including Mark Page and Dave Matthews, who are also here at today's meeting. Change focused on HIV stigma and homophobia because they've been intertwined in the U.S. since the beginning of the HIV epidemic, and because empirical evidence finds that both act as barriers to uptake of HIV prevention and care, including testing, ART, PEP and PrEP at various levels of the social ecology. We organized change to shift stigma and homophobia at the community level separately and in combination in order to increase access to testing, care, and prevention using multiple intervention components. It reflected key aspects of Lincoln Phelan's model of the stigmatization process, particularly the essential functions of stigma to keep people in, out, or down, which also demands attention to whose interests are advanced through stigma and discrimination. It was steeped in the theoretical and lived expertise of the study team related to the critical role that community cohesion, mutual aid, and solidarity play in the surviving and thriving of communities of color in the context of a white supremacist U.S. society. This hinged on the protective function of community, including perceptions around the stigmatization process as protective, and community members' deep desire to protect loved ones from the external harms of U.S. society by keeping members in a safe community. Finally, it was based on the notion that communities have the capacity to identify and solve their own problems. Thus, the first phase of change involved a series of steering committee meetings to inform the design and conduct of the study, and the whole project was, as I said before, a community academic partnership. To evaluate it, we used a quasi-experimental matched community study design. The intervention and control communities were predominantly Afro-Caribbean in the same borough of New York City, but not adjacent to one another. The explanatory change model posited that community-level stigma and homophobia, specifically enacted stigma and discrimination, leads to individual-level internalized stigma and shame, anticipated stigma, concealment of sexual identity, non-disclosure of both sexual behavior and HIV status if positive, which reduced direct access to care and prevention. As well, experiences of stigma and discrimination, including family rejection, institutional violence, for example, in schools or healthcare settings, increased psychological distress, which increased negative coping skills like alcohol and drug use and sexual activity that enhanced HIV vulnerability, and decreased access to care and prevention. Finally, these combined to increase individual risk of HIV infection transmission, which increased community viral load. The main change components, which were adapted from program components developed by GMAT and Canva, included workshops and trainings for CBOs and businesses, street-based pop-up events, as well as a fixed-based event, and a universal prevention message. Within each component, our model of change focused on reducing engagement in enacted stigma among community members to improve community health, and integrated sets of intervention techniques, including enhancing visibility, increasing contact, educating on stigmatization, processes and effects, enhancing empathy and perspective taking, challenging stereotype beliefs, raising critical consciousness, and teaching skills to analyze and interrupt stigma and homophobia. Okay, sorry, the animation is a little slow. So we had events at a fixed space. We also had pop-up events, which were designed to enhance visibility and increase contact. And we had workshops and trainings that were designed to train individuals and community-based organizations on how to interrupt stigma. And finally, we had a universal prevention message that was designed to raise critical consciousness and again, enhance visibility. Change addressed stigma and homophobia separately in combination, so we conceptualized it both as additive, like a double whammy, and also as interacting to exponentially increase the damage done by both of them. Most critically, we conceptualized homophobia as a system of oppression, a notion that was well understood by the Afro-Caribbean, Black, and African-American community residents that we were working with. Our evaluation used pre- and post-intervention serial cross-sectional surveys in both intervention and control communities, and we adjusted via propensity score matching and used GE models to assess its impact. Unfortunately, we did not detect an impact of the intervention on the community level attitudes, but we did see a 350% increase in HIV testing at the fixed community site. Sorry, I'm advancing my own slides slowly. So there were many challenges of change. These included the large spatial boundaries that reduced penetrance, potentially reduced penetrance and intensity, and increased the potential for positivity violations, potential for contamination across communities. You know that buses travel, and so bus shelter ads might have been seen among members of the control community, potential unassessed lagged effects, social desirability and outcomes, and a lack of archival data to efficiently evaluate the intervention. Those last two were discussed at length by others earlier. Something that was not a challenge but was a critical context with change was that that as we were implementing it, the Black Lives Matter movement was spilling out onto the streets of New York City after the murders of Michael Brown and Eric Garner by police. This movement was inherently intersectional, reflecting the intersectional identities of the women of color, two of whom self-identify as queer, who founded the movement. Like the Black Lives Matter movement, the change intervention components were designed by and for communities of color. The Shoe Drop event was designed by CAMBA. The CBO training and bus shelter campaign had been designed by GMAT. BMK, the space in the intervention community, was led and staffed primarily by gay Black men. We believe that this is why an intersectional approach that centered the experiences of racism and people of color in the context of white supremacy was baked into the change components because they were designed by and for Black people and for other people of color. And while change was co-led by Vaughn Taylor Kutagawa, the executive director of GMAD, and myself, when the chance to adapt the intervention came along through our new study called CHARGE, GMAD as an organization had suffered severe funding cuts and was in the midst of a reorganization. This reflects a massive challenge faced by intersectional organizations that take a holistic approach to community health, which is the lack of investment that would allow a non-fragmented approach to community health, in this case, gay Black men's health and well-being. Other challenges that we face are emergent stigmas. We know about emergent stigmas related to COVID, but in particular, we have evidence of emergent stigmas related to HIV testing and to PrEP and PEP. We developed the CHARGE study to respond to both the methodological challenges of evaluating a community-level intervention and to address emergent stigmas that have been found to act as barriers to HIV testing and prevention. So the study involves applying a systems thinking methods approach, informative research, ideating and prototyping new intervention components, and piloting the adapted intervention using optimal study design features. A critical explicit focus of the intervention is on interrupting novel and intersecting stigmas and discrimination in the context of a racist society. Thus, the new name CHARGE includes an R for racism. Our study team includes many of the same members. We also have new experts in design thinking, and we are currently focusing now on causal loop diagramming, a key component of the model building process to characterize how known and novel stigmas intersect to impede testing and prevention. The approach allows you to develop complex models that you can test via simulations to estimate the impact of changing specific parameter inputs. And we're currently elaborating on existing stocks or variables in Dr. Lounsbury's and colleagues' existing model by conducting focus groups and in-depth interviews with key informants, experts on various aspects of the overarching system, including service providers, gay men of color, and community residents. These are examples of the new causal loops that we are developing. And once we complete this phase, we will engage in ideating and prototyping the novel components in consultation with intervention design experts. These will be integrated into the existing change components, and then the reconfigured intervention will be piloted using optimal study design features, identified in consultation with a team of methodologists expert in evaluating area and community level interventions using some of the novel methods that Mark noted previously, like archival, big data, as well as capitalizing on ongoing longitudinal and intervention studies, sort of like what Jonathan has been talking about. The CHARGE team now also includes MOBI, Mobilizing Our Brothers Initiative, an entity that curates social connectivity events for queer people of color where they can see their holistic selves while promoting community wellness and personal development. MOBI exists in both the virtual space as well as in real life, a crucial engagement approach in our new normal where almost everything has been or can be virtual. But we continue to face a leadership challenge in CHARGE with a gap in gay Black study leadership, which reflects the institutional racism of academia. And we are actively discussing this issue and really challenging ourselves in it. We're talking about whether I, as a white cisgender woman, am a trustworthy partner. We're attempting to also address it through a flatter, more democratic study team organization and elevating into leadership roles of longtime team members who may not have backgrounds in science or PhDs. But the fact remains that studies about stigma, homophobia, and racism really do need to be led by people of color from the communities most affected, which has been said already several times today. It is our hope, though, that the adapted CHARGE intervention, I think I somehow skipped over the MOBI picture. There you can see some pictures. It is our hope that our adapted intervention will reflect the intersectional social movements as well that are, again, spilling out onto the streets in New York City and all around the country and transforming our society. This is the spirit we're trying to channel. Thank you.
Thank you. Thank you very much, Dr. Fry. I think I especially appreciate the fact that you've shared a lot of the challenges of implementing intersectional stigma interventions and being very honest and open about that. So I hope that'll stimulate some good discussion. So we will move now to our next set of presenters, Dr. LaRon Nelson of Yale and Laura Nyblade of RTI, going to share with us some work that they've been doing in Ghana.
Okay, I hope you can see me. I can't.
Hi, Laura, you ready? And I think we have Dr. Nyblade with video and Dr. Nelson by voice.
Hi, LaRon, you're not logged in.
Oh, you can't hear me.
We can hear you.
We can hear you. We can hear you.
Oh, I'm trying to share. Okay, well, I'll just talk and advance the slide. So good afternoon. It is my pleasure to be here with my partner, Laura Nyblade, to tell you about the study we're leading in Ghana of a multi-level intervention addressing intersectional stigma to improve HIV testing in men who have sex with other men. We want to first start by acknowledging our team, which includes academic partners at the University of Ghana School of Public Health, the Ghanaian Civil Society Organization partners, and familiar names in intersectional stigma research like Carmen Logie, who's at the University of Toronto. So, in this study, intersectional stigma is conceptualized as HIV stigma, same-sex stigma, and gender nonconforming stigma. Our approach to this work is guided first by the socio-ecological model, which addresses the multiple overlapping influences of intersectional stigma operating at various levels to impede HIV testing. We focus on addressing intersectional stigma at the organizational level, concerned with the climate within healthcare facilities and the ways in which that might impede testing. At the interpersonal level, which is the group of social networks of other men who have sex with men, and the climate, the relational and social climate that's created within these networks, the norms that can either be supportive or undermining of HIV testing. And also at the intrapersonal level, dealing with the internalization of intersectional stigma. We also use Brian Wiener's convergent framework, which is a model for how and why to combine multiple interventions that are operating at different levels. And again, this was necessary because the influence of intersectional stigma on HIV testing is operating at multiple levels.
Thanks, LaRon, for setting the context for our study. And now I'll start out by sharing a bit about how the study is operationalized, with some details about the study design, and then we'll talk about the interventions at each level as well as the measures that we're using at each level. As others have said, we have unfortunately had our study paused by the COVID-19 pandemic, but we hope to get started again soon. So our study design has two phases, and I'll start with the first phase here. And in the first, and this is the formative phase, we begin with focus groups and in-depth interviews with both men who have sex with men and healthcare facility staff. This formative work will sharpen and deepen our intervention content and the combination of the interventions at the three levels by examining the drivers and manifestations of HIV, same-sex, and gender nonconforming stigmas within health facilities and within MSM peer groups. It will also help us understand how these intersecting stigmas undermine HIV testing among MSM, which is our key outcome. In addition, they will also provide perspectives on strategies for reducing intersectional stigmas within healthcare facilities and among peer groups. Once this data has been collected, it will be used to refine the intervention content as well as the integration of the three levels. And it will be reviewed closely by a work group of Ghanaian MSM and healthcare facility staff. Once we have all of this input, we will generate a manual, which will then be further reviewed by topic experts, and then we'll further refine it, have a rehearsal before we enter into the trial phase. This multi-level intervention seeks not only to reduce stigmatizing interactions in health facilities and among peer groups, but also to build skills, agency, and social assets among MSM peers and within healthcare facilities to challenge and reduce intersectional stigma. We also aim to strengthen partnerships between healthcare facilities and MSM civil society organizations for intersectional stigma reduction through the joint design and implementation of this intervention. So our next stage, which is the trial phase, involves 8 healthcare facilities in 2 urban areas of Accra and Kumasi in Ghana. They'll be matched by city and size of staff. Each matched healthcare facility pair will be randomized to have an intervention, which we'll talk about shortly, and a control arm. Before assignment to healthcare facilities, 216 MSM recruited through peer-driven methods will be randomized to receive the intervention, both at the peer level and at the individual level, or routine standard of care. Each arm of the MSM will be assigned to the healthcare facility in the corresponding arm, intervention or control, and asked to stay in the assigned healthcare facility clinic pipeline for HIV testing prevention services. This is a waitlisted design, so all MSM will eventually get the intervention. So now we'd like to turn a little bit to share about each of the interventions and the measures we'll be using. There we go. So I'll start by talking about the healthcare, the organizational level at the healthcare facility. We're going to be adapting the Health Policy Plus HIV Stigma Reduction Total Facility Approach. And there's a purpose to the word total, which I'll talk about in a minute. This is an intervention that has been tested in Ghana, Tanzania, and Thailand. And it's HIV focused, but we've had elements of addressing same-sex stigma and also stigma towards adolescents seeking sexual and reproductive health in these countries. So we'll be building upon that to address the intersectional stigmas of HIV, same-sex, and gender nonconformity. What we'd like to highlight about this intervention, and we have materials that are written up about how it operates or how it's implemented, is that it's built on over 2 decades of both research and programmatic work. And it recognizes the importance of everybody in a health facility, not just the clinical staff, in creating an environment that is stigma-free. We've learned from our work that oftentimes intersectional stigma or individual stigma starts at the gate and oftentimes or at the reception, and oftentimes clients do not even get to the clinical staff. So it's important to involve everybody. We also find that it empowers lower level staff in health facilities who are often experiencing a different kind of stigma to know that they actually play a very valuable role in everyone's healthcare. So it involves all levels of staff who have face-to-face interaction with clients. It's key that it is delivered by and designed by health facility staff and clients together, working together. That becomes already a stigma reduction intervention, is this designed together. So we start with the analysis of the baseline data where staff and clients work together to actually look at what has been collected, identify the stigmas that are happening, and begin discussing and deciding on how they will move forward to intervene. We have participatory intervention, stigma reduction intervention that's delivered. This is delivered by staff and clients from the health facility who are trained to deliver the intervention. So the intervention is not delivered by outsiders, but by staff and clients from that facility, which is really important. And lastly, we have facility champion teams that we have found emerge organically from these trainings, who then work on some of the more, some of the issues that have been identified through the training and the baseline data collection. Most often these are about space or institutional issues around policy. So within the health facility, we're intervening at the individual level, but also at the structural, the small structural level of the health facility. And at the health facility, we'll be using multiple measures to assess how the intervention is working. We'll be measuring HIV stigma and discrimination among health facility staff in different ways. There's 6 domains that we use there. We'll be using the LGBT phobia attitudes and cultural competence scale, as well as the gender equitable men's scale. And so with that, I'll pass it back over to Laron to talk about the other levels.
Thank you, Laura. So we have 2 other levels. One is the intrapersonal level, which is really trying to deal with intersectional stigma that has been internalized among MSM. And the intervention that we're using for that is called HIVE-3, HIV Empowerment, Education, and Empathy. As Laura mentioned, all of these interventions will be adapted to enhance their focus on intersectional stigma. But this intervention is a peer-based intervention that it uses mobile. It's a mobile web app, and it's based on the peer support model by Cindy Lee Dennis. It identifies 3 types of support, which we hope will build resilience and counteract narratives of stigma from being internalized among the MSM. So this is informational support, emotional support, and affirmational support. This model uses local peer mentors that will nurture social emotional resilience among the men, again, that we hope will mitigate the internalization of intersectional stigma. This is an intervention that has been previously implemented in Ghana with MSM. And the interpersonal intervention, which is the group level between person intervention, it's called Yansapo, but it is based on Many Men, Many Voices. Many Men, Many Voices is a CDC-designated best evidence intervention. It is group-based. It has shown efficacy for increased HIV testing and showing few episodes of condomless anal intercourse among when it was tested in New York City, in Brooklyn, in a place where Victoria's doing her work. So we use that. It addresses behavioral and social determinants of HIV risk. And we did also previously implement this in Ghana. It was actually adapted previously for use specifically with MSM in Ghana. Some cultural adaptation, some social, some language, but much of the logic underlying many voices did not change. So again, the plan is adapted to address intersectional stigma, addressing HIV stigma, same-sex stigma, and gender nonconforming stigma. We measure this using a latent variable of intersectional stigma that we actually used in previous studies, but one is the HIV stigma scale, which has the 4 subscales you see listed here, the same-sex stigma scale, and the gender nonconforming stigma scale. So those are the 3 manifest variables that we're using, and we'll use that latent variable as our measure of intersectional stigma among the men in this study. So for our recommendations, some of the things that we're thinking about, and it will be important for you to consider as well, is how to expand and test these types of intervention elements to address stigma that also impact cisgender women, but also transgender persons as well and adolescents. So in the process of us understanding, working with our community partners about how to implement this, these are some of the things that are coming up. There are some assumptions about how we think groups are organized by saying we're focusing on groups of MSM, which don't account for the fact, for the other ways, for all the ways that queer men, heterosexual men organize themselves, which don't only include MSM, other MSM. It's important to also capture and accommodate the fluidity of gender identity. So this assumes that people are men at the time they enter the study, and they'll be men throughout the study. But just on some of our work in Ghana, we understand that people's gender identity is fluid, and thinking about ways to have studies that can accommodate for that type of fluidity and what challenges that might have for outcome measurement. To engage community partners throughout the process, from proposal development on through dissemination, and also the importance of cultivating government engagement at the healthcare facility level, particularly in places like Ghana, where many MSMs do rely on public health facilities. But the entryway to those facilities are through some pretty sophisticated diplomacy that our local partners understand how to do that work. But that's important work that must be done if you're going to do projects that can be scaled to a degree and have the type of impact that we're trying to have in these communities. Thank you.
Okay, well, thank you so much. And we are definitely going to look forward to seeing what the results when you're able to implement and test these interventions. I think it's a really good example of, again, combining both the structural and the individual level interventions in one approach. So now I'd like to just move forward and introduce our next speaker, who is Dr. Laura Bogart of RAND, and she's going to tell us about some exciting interventions they've been developing. Okay, thank you for the opportunity to present today. I'm really grateful for this opportunity. And I'm going to be presenting on a group-level community-based cognitive behavioral therapy, or CBT, intervention to increase effective coping responses to intersectional stigma, address medical mistrust, and improve health outcomes among Black and Latinx immigrant sexual minority men. These projects were developed with 3 pilot studies with community engagement with people living with HIV. They were developed with the Family Institute and Multicultural AIDS Coalition in Boston, and Vienna Star Human Services and APLA Health in Los Angeles. And I'll be presenting some of the results of the pilot study today, but we also have 2 in-process RCTs now. The first one, Still Climbing, is the one with Black sexual minority men. It was named after a line in a Langston Hughes poem. And it's to increase preventive care engagement and receipt of evidence-based preventive care among Black men. And this is regardless of service status, because we heard in our pilot work how men really wanted us to expand the intervention and talk more holistically about their health in general. The second one is called Siempre Seguiré, and that's from a line in a song that's become a gay anthem of empowerment. And both of these were named by community partners. This one is the PRISM study, and it's increased HIV testing and PrEP use among Latinx immigrant sexual minority men of HIV negative or unknown status. So I want to start with an analogy of a burning building, because a lot of times when I present this to community partners or in academic circles, I get the question, why are you focused on the individual level and building resilience when we really need to change the structures of society? So a community partner actually at Fenway Health came up with this analogy to talk about the study, to say that if there's a building that's on fire, you don't keep the people in there and put out the fire. You engage in efforts both to get the people out and to put out the fire, and then to figure out why did the fire start in the first place, so we can prevent these fires from starting in the future. And so that's what this intervention is trying to do, to build individual level awareness and resilience around racism and discrimination, so that we can take action more at the structural level once we're aware. And I also put a quote up here from Kareem Abdul-Jabbar, who wrote a recent op-ed in the LA Times that also used this burning building analogy that I thought was very relevant to the study as well. saying African Americans have been living in a burning building for many years, choking on the smoke as the flames burn closer and closer. And he talks about how racism can be invisible until you build awareness and you notice it. And then you can shine a light on it and stay vigilant because it's always in the air. So to talk about the intervention content and structure, it's the same across both interventions for Black and Latinx men. So it's 8 community-based group sessions, so run like a support group with a peer counselor using CBT strategies. So using CBT strategies, we teach participants about how to conduct a behavioral analysis of their thoughts, emotions, and behaviors in response to intersectional stigma and discrimination, and enhance their awareness of stigma and discrimination, and figure out adaptive ways to cope while still maintaining their life values and goals. And we also want people to practice it because it's a CBT intervention, go out and practice it in their daily lives and then come home, come back to the group and talk to us about how did it go, getting feedback from the group about different strategies people used and different reactions that they had out when they went outside of the group. So we integrate intersectionality, so participants discuss how their multiple interlocking identities comprise their holistic sense of self. And we also talk with them about processing stigma and discrimination and how it affects the whole of their identity rather than the separate components of it. The session topics here, we start with psychoeducation about stigma and discrimination and defining it so that people are more aware when it happens. We do have people in the group who aren't always aware when they're experiencing it, and this helps them to share what other people's experiences are and also to model how other people respond. We talk about the definition of intersectionality and their identities. We talk about how to use the CBT model, which I'll show you an example in a moment, and how to identify and overcome barriers to effective coping. And then we talk about medical mistrust and internalized stigma as 2 forms of coping that can be ineffective. For example, maybe leading to lack of engagement in healthcare or health behaviors. And we talk about social support as an effective form of coping. And we close the sessions with a discussion of structural discrimination. We provide resources for participants, local resources, how they can take action in their communities, how they can continue now that they're empowered to go out and identify discrimination and do something about it. So here's how the CBT model works. So we talk with participants how there's an event that they might interpret as discrimination. And then they have a reaction, a coping reaction. So we talk about how they might have internalized thoughts and feelings. So they might feel like they deserve this. They might feel shame, anger, fear, sadness. And we talk about how they might do behaviors that may not always be effective in the moment. They might display anger. They might conceal their identities, which over the long term may be hurtful to their health. They might avoid certain people and places, which can be a survival strategy, but sometimes may be ineffective if they're avoiding health care, for example. And then we talk about how to apply the CBT model to these reactions. So there's an event that they interpret as discrimination, and they may say, oh, this is one of those times I need to think about. And they have their coping response. And so one thing we found in our pilot work, in our qualitative pilot work, a lot of people who had more resilience in response to discrimination externalize rather than internalize. And so, that's about the other person. It's not about me. And we also talk about different feelings and behaviors that may be more effective. For example, feeling strong, not allowing this person to get in their way, showing self-compassion, feeling self-compassion, and also going and getting support from people who may share similar identities, such as in our group. So 2 of our pilot tests were randomized controlled trials. So climbing, we found increased effective coping in response to stigma. This was measured by the brief COPE and the Afrocultural Coping Inventory in terms of more active problem-solving coping, use of humor, and use of self-protective strategies. And for Siempre we found increased adherence. This was among people who were positive, so increased adherence to antiretroviral treatment, decreased negative religious coping beliefs. So for example, not feeling like it's a punishment from God when they're discriminated against, and decreased medical mistrust in the form of HIV conspiracy beliefs, and reduced internalized HIV stigma. We also found high acceptability of the intervention in all the groups that we've run. So for example, in Still Climbing, someone said, I'd recommend it to all men, all Black men living with HIV. And then he ends by saying to every person that's a minority. And this led us, this and similar comments, led us to make it a more holistic intervention, not just for people with HIV, but for everyone to talk about these issues. And from the other intervention with Latinx men, we said, this person said, you realize you're not the only one, you know how to deal with situations. So clearly the intervention shows promise, but more work is needed. So we've shown it's feasible and acceptable, it has preliminary effects on coping, stigma, mistrust, and adherence. It can be sustained by peer counselors in community-based settings, and such as support group structures. And we're hoping that these in-progress RTTs provide effectiveness data on other health outcomes. But clearly, as I mentioned, individual level interventions are insufficient, so we can empower participants and provide resources and support to be change agents, but we do need complementary interventions to address structural discrimination. So I just wanted to acknowledge the funders, many of whom are here today, NIMH, LAR, NIMHD, community partners and co-investigators, and give a shout out to Ron Brooks and Joanna Barrera who are here today, and Tanisha Dale, who participated in the study through Fenway. Thank you very much.
Thank you very much. Okay, well, we're doing all right in terms of our time here, but we'll now move on to our last set of presenters. Dr. Jay Savelius and Dr. Sherry Lippman of UCSF are going to share some work, some exciting work they've been doing in Brazil. Thank you.
Okay. Well, hopefully Jay will be able to call in again. So I want to first thank everybody for including us today, and apologize that I'm looking this way because the slides are over there, even though the camera's over here. So our project called Manas is, which is a slang term sort of for sisters, is about reducing intersectional stigma among high-risk women in Brazil to promote uptake of HIV testing and also PrEP. We have a lot of partners in this study, and I want to start out by talking about the academic partners. So Jay and I are MPIs on the study, and Dr. Gustavo Figuesi is our project coordinator at UCSF. The site PI is Maria Amelia Vera. She's at the Santa Casa School of Medical Sciences, and we also are working with the NUDIS LGBTQ plus Human Rights Study Group. Our study director there is Zé Luis Gomez. And our clinical sites include both municipal and state-run organizations, the Reference Center for HIV/AIDS, the CRT in Sao Paulo, and also the Sci Campos Elíseos. I also want to say while we're here that we thank the NIMH for funding the study. Okay, so in terms of background, the epidemic in Brazil really is focused on key populations, and trans women or transgender women experience 20 to 30% HIV prevalence in southern Brazil, where the study takes place. The infection rate among transgender women is over 55 times that of the general population. Prevention in Brazil really is lacking for the transgender community. PrEP is available, but only about 335 transgender women had initiated nationally by the end of 2019. The low uptake is not attributed to lack of interest or to eligibility. The low rates of testing are also not commensurate with the risk of infection. I think Jay might be back. Do you want to?
Can you hear me now?
Second? I can.
Excellent. Sorry about that. I had to log out and log back in. Where did we get to?
Just went through the prevention. You want to talk about intersectionality next on the background?
Sure. So of course, as part of the PRISM initiative, the Manas intervention really
looks at the experiences of transgender women from the lens of intersectionality. And we think about the confluence of stigmas related to social identities and how those structural stigmas are reflected in the personal experiences of transgender women based on their gender identity, their race, whether or not they participate in sex work, substance use, and their experience of HIV stigma. So the evidence base for our intervention really comes from peer-led programming that Sherry and I both have been involved in developing in collaboration with communities that target individual level factors, dyadic factors through peer-led interventions with participants and group-level interventions, and really coming from a place of thinking about empowerment and how to leverage networks that already exist among transgender women and other key populations that we've worked with. So the objectives of the MANA study are to address and reduce the negative health impacts of intersectional stigma that transgender women experience in order to improve HIV prevention strategies. Our first aim is around HIV testing. So we seek to determine whether HIV testing uptake is higher among trans women that participate in MANAS. MANAS por MANAS was one of the names we were considering. We're now going with MANAS. Compared to waitlist control arm. Aim 2 is HIV prevention, determine whether PrEP initiation and persistence is higher among trans women in MANAS compared to the waitlist control arm. And our aim 3 is looking at the mechanism. So really looking at changes in intersectional stigma, including reductions in internalized stigma and increased resilience to anticipated and enacted stigma, and assess how these changes impact HIV prevention. So the MANAS intervention combines 2 evidence-informed interventions that Sherry and I have been working with for a while. One is at the group level and one is at the individual level. So the conceptual background, I see our figure got a little distorted here, but we have 2 conceptual frameworks that we're really drawing from. One is the gender affirmation framework, which really looks at how both need for gender affirmation and access to gender affirmation impacts transgender women's experiences of intersectional stigma. And access to gender affirmation includes things at the structural level like access to health care. It also includes interpersonal stigma or interpersonal affirmation in terms of affirming relationships that transgender women might experience. And then this kind of stigma process, which is how people are able to pass or not pass or be read as cisgender, and how that can enact stigma interpersonally as well as structurally. And then the need for gender affirmation really came out of Black transgender women's sort of collaboration on this theory, thinking about how this differs within transgender communities in terms of people's desire for things like transition-related medical gender affirmation, the differences in people's desire to be affirmed as female versus really claiming a transgender identity and really living as trans, and the fact that all of us experience more or less levels of gender affirmation, but that cisgender people in particular sort of take this aspect of affirmation for granted. And this comes really out of identity affirmation theories and collaborative work with transgender communities. And then, of course, intersectionality as one of our conceptual frameworks. And this particular figure is from Lacombe Duncan and focuses on transgender women living with HIV and the different types of structural stigmas that transgender women living with HIV can experience, but really is rooted in, of course, the work of Black feminist theorists such as Kimberly Crenshaw and the amazing work of our intersectionality researcher, Lisa Bowleg. This is the conceptual model for our for MANA, for the intersectional stigma reduction intervention, and is really focused primarily on intervening at the level of stigma experiences, internalized stigma, anticipated stigma, and enacted stigma.
So there are these structural stigmas that are reflected in transgender women's experiences, and what we're looking to do is to intervene with a peer-led intervention, so at the individual level through dyads, peer navigators and participants, and group level where we are building and strengthening networks of transgender women that exist already and sort of leveraging them to provide HIV-related information, to reduce stigma around talking about HIV, and to also to help transgender women brainstorm about different ways of coping with stigma and actually practicing those experiences. And what we hope to see is that health behaviors such as increased self-care, reduced avoidance behaviors that often result from traumatic stigmatizing events, and increased stigma resilience will result in increased uptake of HIV prevention.
Great. Okay, so the MANA's intervention is set up in two parts. The first is a peer-led group work that takes place over 5 sessions and then meets after a few months for a reunion session. The sessions are based, as Jay was noting, on our successful adaptation of other programming, including the SHIRO's intervention that was originally done in the United States but adapted in Brazil 2 years ago, and also some of the group work we did during our Trans Amigas peer navigation program in Brazil in 2018. So the content was really heavily shaped by community input, and we're also selecting peer leaders in pairs. We're aiming to have both an HIV positive and HIV negative peer navigator leading each group so that we can address HIV-related and PrEP-related stigma head-on. The peer navigators are going to lead groups of 8 to 10 participants through group work designed to bolster trans pride and gender affirmation, also to address HIV prevention as well as safe transition practices, and to address experienced stigma in the community setting, in the healthcare context, and within their relationships. So as Jay noted, we're offering tools for resilience. And then once the group sessions are completed, each participant is going to be assigned to one of their 2 group leaders for 6 months of one-on-one navigation support. That's designed to help the participants with their experiences of stigma and other barriers to prevention and well-being in the healthcare context to support them as they continue working towards prevention, well-being, and also gender affirmation goals. And they set these goals for themselves with their navigator. The individual navigation program is also based on the Trans Amigas study and is a combination of structured activities and also unstructured check-ins. So we've provided the titles of the group sessions here to give you a sense of sort of the tenor of the work they're doing. So for example, the session on gender pride, the first one, explores trans identities and gender pride through identifying positive role models that combat internalized stigma, and also introduces HIV prevention options in relation to this concept of self-care. And for example, the session on Taking Back the Power discusses how trans-related stigma impacts one's sense of personal power and explores ways to reclaim one's power in confronting stigma. So during that session, the participants they explore assertiveness skills and practice communication skills for the healthcare context. So these are all learning tools to challenge structural and interpersonal enacted and anticipated stigma. So in each group session, we also include a moment to discuss and reflect on one SHIRO, or trans woman hero, someone who inspires others with their work and their achievements. And we've also integrated guided visualization and mindfulness work into the gender affirmation exercises, which is now, of course, doubly important in this time of increased anxiety in COVID-19. So just in terms of COVID-19, part of the individual navigation work also includes referrals to needed social services, and our partnering group, New This, is currently mapping COVID-19 resources for the transgender community that's going to be integrated into our navigation program. There we go. So the study is a randomized waitlist control trial in which we will allocate 200 participants to immediate intervention, which again includes approximately 3 months of group sessions and then 6 months of individual navigation. And the other participants are going to be randomized to a waitlist control, so they'll all be offered the same intervention 1 year later. The main trial phase includes 1 year of person time for every intervention and waitlist control participant. And the second phase of the study, the delayed intervention phase, gives us an opportunity for the control arm to receive the MANA's intervention and simultaneously to follow the intervention arm participants for a further 6 more months so we can look at the persistence of effects. I think I don't have much time, so I will move forward. Okay. So the rolling enrollment of 400 participants will take place over 1 year, and the recruitment of participants is going to happen from multiple sources, including standing cohorts and those accessing services at our partner facilities and also through community outreach. Data collection is going to be conducted at our nudist office and also at the other participating clinics. And we'll be doing clinical monitoring of PrEP through the National Medications Dispensing System, and also collecting dried blood spots for testing drug levels among those on PrEP to measure adherence. So just to note that we are measuring intersectional stigma using the Intersectional Discrimination Index by Shyam Bauer, I hope I pronounced that correctly, including the subscales for anticipated stigma as well as enacted day-to-day and major discrimination. These are all attribution-free measures, so the items are prefaced with questions about experiences related to who you are. We're also using an adapted version of the Resilience to Stigma measure, and for consistency, we also preface that measure with because of who you are and don't reference any one social identity. So just to note that we're slowed down by COVID like everyone else. We're hoping to begin in October or November. And so some of our focus right now is on adapting to COVID-19 and ensuring that our navigation team gets all the needed training on the original MANAS content as well as COVID-related resources. And I just want to say community well-being was already fragile following the last presidential election and the administration currently in Brazil that's very unfriendly to gender and sexual minorities and to public health in general, as was illustrated when they recently took down the country's COVID tracking website and also the HIV/AIDS page. So COVID-19 is only serving to magnify the vulnerability in this community. Okay, and with that, I'm just going to dedicate this presentation to Bruna, who was an activist and a star peer navigator on our last trial and an inspiration to everybody. Thanks.
Minutes for discussion, and which is great. So we have some time for questions. I have one question here in the chat from Christina Rodriguez-Hart asking the last presenters, do you think the term high-risk women can be stigmatizing language?
Yeah, can I say something about that?
Yes.
You know, that's actually the formal title for the NIH proposal, and I do think it's stigmatizing language. You know, I've actually had experiences in the past where having transgender in the title of my NIH proposal meant that there were groups that would Google that, or not Google, but like look for that term in NIH Reporter, and I have been the target of transphobic kind of activity in the past for putting transgender in the title of my NIH proposal. So every time we submit a proposal, we have to weigh, you know, the public information that's available about it and how reviewers also understand. So I think the questioner raises a really good point that it probably makes sense for us to use more of a lay title when we're presenting our study. Yeah, so that's one of the issues that has been raised.
Thank you. Thank you. That's great. Okay, we have another question here from Ali Talaran. It's for Dr. Bogart. It says, I appreciate your CBT-oriented approach to empower folks, enhance coping skills related to experience of stigma. You mentioned a few times that complementary interventions are vital to address structural discrimination. I'd be interested to hear your thoughts on integrating DBT-based techniques and concepts such as distress tolerance and radical acceptance into interventions focused on the interpersonal and or community level. I hope I was able to convey all that. Oh, thanks everybody for coming back.
Hey, thanks.
Laura, did you get that?
I think I got it. I'm not sure I'll be able to answer it sufficiently, but I'll try. I mean, I can say what we're doing and trying to integrate our basically CBT intervention with the community and describe that a little more. It may not, if I could use further clarification of the question if it doesn't answer it. But basically we're providing, as I mentioned, We're empowering people to go out into their communities for change, and we're providing resource lists and talking about how can they make change for all of their identities. And of course, a lot of the resources out there are for one of their identities, like the local Black Lives Matter chapter, or getting the vote out to try to work with local policymakers and try to figure out who's best serving their needs and who would be best to vote for, and getting the vote out in that way, and doing all, so trying to figure out where in their communities can they be empowered to actually make change, starting at the ground up. Although I recognize that leadership is needed also from policymakers to make the change, and structural changes are needed.
Great, thank you. Okay, I have a question for Dr. Fry. I was just wondering, you had a lot going on, obviously, in your interventions, and I'm just wondering, is it possible on any level to disentangle all of these multiple intervention activities and figure out, which ones are most important or most impactful?
Can you hear me?
Yes.
Okay, sorry, the whole screen just blanked off. Presently, no. The way we designed the original change intervention, the idea was that the entire intervention package would have an impact at the community level, and that we would be able to detect average or aggregate impacts on community level attitudes or social norms. But in charge, we are, in recognizing the methodological challenges that we faced, we are trying to improve upon that evaluation approach, and that is absolutely one of the goals, is to be able to at least evaluate certain component parts, and possibly even at the individual level if needed, in order to identify more clearly impacts of the intervention component.
Certainly, it's a challenge, and and again, maybe it's the package of everything together that works well. But so yeah, we'll look forward to seeing what you can do with that. Okay, I think here's a comment from David Matthews. I think it was Laurent who spoke to the implementation of interventions to Ghanaian youth. What were some of the cultural adjustments needed to help make the intervention more relatable to participants?
Thank you. It was things like, so for example, at the end of Many Men, Many Voices, which was adapted for Yansifo, at the end of the session, people just sort of go back to their neighborhoods. And in Ghana, there was this sense that there needed to be some group formation, like actually that it wouldn't be enough to come to have this experience and then for that to be it. That 3-day retreat experience needed to, that group, that was a different relationship that needed to be named, and the leader needed to be identified, which I guess in some ways we might have saw that in America, but it was very clear in, at least in the Ghanaian context, that these groups were then, they came together just for the purpose of the intervention. We're going to be called, I don't know, Birds of Paradise, and Laurent was going to be their leader, and they were going to, so that was something that we had to build in that we didn't think about doing. We hadn't done that in U.S. context. Or one other issue was about being bisexual. And so in the original intervention, we don't spend a lot of time talking about being bisexual. It's stigma around being black, being gay, being a black gay man. And people in Ghana, it was also very interesting, this idea of what it meant to even be gay they challenged that. Because many of the men have sex with women, some because they have to for cover, some because they like having sex with women or having relationships with women. And so it changed how we had to think about how we were in the intervention categorizing people who rejected this nomenclature. that they were gay men versus men who have particular sexual desires that they enacted whenever they chose. And so those were things that were definitely not how the American version was structured, that we had to adapt to make sense in the Ghanaian social context, even about how they understood themselves in the ways in which different identities get stigmatized. The label itself, and I think J-Man mentioned this earlier, was stigmatizing. The fact that you had to sort of be in a box in and of itself was a stigmatizing process. I hope that helps answer the question.
Thank you. Maybe we have time for one more question from Marcia Ellis. Has anyone looked at how stigma is addressed at the household level, where positive mothers or guardians might have to moderate their own openness about their status and HIV journey in order to protect their children's privacy and stigma that they might face? I don't know if anybody has, maybe Dr. Lippman or Dr. Sebelius, anything about how people deal with children and issues with children?
Sorry, I haven't actually addressed that directly in my research. I think Margarita Lightfoot has a fair amount of research on this topic, and unfortunately she's not one of the panelists right now, but I would encourage the person asking the question to reach out to her. I think she might be on the phone, but I'm not sure if somebody else has.
Okay. Can you all hear me now? Still? Yeah. Yes. Okay.
Yes,
good.
we can.
I saw that. Okay, good. I feel like my audio is going in and out. Okay, let's see. Maybe we have time. Greg, do we have time for one final question, or do we want to need to wrap up at this point?
Yeah. One final question. That'd be great.
Okay. This is from Ugo Amanyehue. How much traction are your different projects and programs getting with the government and community platforms towards addressing stigma as your data is showing them? Are you sincerely hopeful that they'll engage and respond appropriately? I'm particularly concerned about the sub-Saharan Africa countries and even here in the USA. So this is about, I guess, the government response. Is this really going, are these projects really going to impact the policy and governmental awareness?
Hi, this is Laura. Can you hear me?
Yes.
Okay, I'd be happy to jump in first on that one, and thank you for that really important question. And I think you had ended our presentation by actually our last point being about the government engagement from early on. And I think it is a challenge, and we do know governments change. But for us currently, we've had engagement by sort of key players in the government at the design phase of the research, so at the proposal writing phase, and continue to engage them as we move forward. We're stalled right now, but we've seen that in other work that I've been part of, that's also been very important. So ensuring that the right people from the government are involved in both the design of the research, in sort of adaptation of the intervention, all helps to build that buy-in, especially around sensitive topics. But it is an ongoing challenge, and as Laurent mentioned, it's a sort of we have to bring out our diplomatic skills, which as researchers we might not always have in big abundance, but we learn them. So.
Yes, I wonder, Dr. Smith, how about in China? Have you had any interactions with the government about the work that you're doing?
That's a great question. In China, we can't do any work without buy-in from the government, largely. So diplomacy, I think, Lauren Nyblade is got to be part of our training for anyone interested in working there, but likely anywhere. We're lucky in that we're working within the auspices of a long-standing relationship between the University of North Carolina and the STD Control Center working in the province that we're operating in. So we're actually able to leverage that name when we're trying to recruit providers and say, hey, we're trying to do a project to improve healthcare quality service delivery.
which is the charge of this organization. And so with that kind of name brand, you know, we can kind of have better luck bringing doctors and sort of participants on board. The hope too is, of course, what we find can then get implemented into long-term strategy. We're optimistic about this aspect because our main contact who runs this healthcare quality control bureau actually wants to use our unannounced standardized patient visits as a technique just to see what's going on in his clinics in the long term. So if we figure out a way to do this sustainably, safely, and reliably, we may be able to actually monitor stigma in the long term.
Great. Okay, well, thanks everybody. I think this has been a great session, and I'm looking forward to working more on this in our working groups in the upcoming phases of this workshop. Thank you.
Great, thank you so much, Janet, and all of our investigators. So we are nearing the finish line, and why don't I invite Drs. Geist, Goodenow, and Rausch back if they're still available, and we can just offer some, brief concluding remarks, including some of the logistics in terms of next steps for the virtual work groups, which will get started shortly. So be on the lookout for calendar invites tomorrow. Drs. Goodenow, Rausch, and Geist, if you would like to turn on your camera and mic, please. I don't believe Dr. Gordon is able to join us, and I know Harold had to get off just about.
Can you hear me?
Yeah, we can hear you, Paul.
Okay. It seems like I have to get turned on. Right. There we go. Okay. Just seems like I think we sometimes get the behind the curtain organizer turns us off and has to turn us back on, I think, at times. So this is great. As Greg has done, we're welcoming back our co-chairs, Dr. Goodenow and Rausch. And they, let's see, Maureen is, Dr. Goodenow has come back in. Great. And our co-chairs, Dr. Goodenow and Rausch, are going to give a few impressions and closing thoughts. And as Greg said, then he and I have a few last points to share before we conclude. Dr. Goodenow will begin, followed by Dr. Rausch. Dr. Goodenow?
So I just want to say thank you to everyone. This has been a fantastic afternoon. As many of you probably know, this is not my area of expertise at all. I'm a molecular virologist. I like to see sequences. I like to see bands on gels. I like to see, transcriptome data and lots of big data sets. This has been quite a learning experience for me, and really continuing the learning experience that I've been on the last 4 years since I've been at NIH, because it certainly is clear that the fantastic discoveries at the basic science level in virology, immunology, cell biology, that then lead to the development of the products that we want to treat, prevent, and cure really are not ever going to be effective if people don't want to take them. And if they don't work in a community environment, it's all very well and good to have boutique types of approaches when one is dealing perhaps with a small population, or a population of people who are a small group with a certain kind of condition. But when you're talking about global pandemics, we need to have approaches that can be rolled out even in different areas that are going to really get to the goals, which are to end these pandemics, whether it's HIV alone or HIV in combination with other conditions, and certainly under the current environment that we're in. So I would like to thank you very, very much. I thought both of the sessions were fantastic. fantastic. I'm so excited about the measurement session, and I'm really looking forward to seeing the results and how that works out. And also in terms of the interventions, I'm somewhat familiar with some of the large intervention trials that were completed a couple of years ago when I was at the Office of the Global AIDS Coordinator, and the combination prevention trials were in my portfolio, and the excitement, the anticipation, and certainly the whole change in the paradigm and putting together studies with that, with those numbers of individuals, I think were absolutely paradigm changing at the time. And I think given how much and how quickly the field moves, of course it presented challenges, but certainly really interesting results. And so I'm very excited to see how these newer intervention approaches are going to work out, and how we can build on those data as well. So I think there's a lot of urgency in what is being done right now. I think one of the drawbacks or one of the complications with the combination prevention trials is they took so long. I think we really need to consider how we can get the important information we need in an accelerated but rigorous way as possible. So thank you again for a fantastic and fascinating afternoon. I'm looking forward to hearing from the working groups and to the session in September, not October. And Diane, turning it over to you.
Oh, thanks, Maureen, and thanks, Greg and Paul. This has been really great, and thanks to all the participants and speakers. And as I said when we started, that NIMH has prioritized stigma research for a long time, and it's not necessarily my original area, although I have become a card-carrying behavioral scientist half of my time. And but I think what's really impressive is how far we've come and how much we've learned over the years. I mean, it's gratifying to know that some of the efforts that we have put in the early days have been able to be built on and grow into something that's so complex, but also potentially so effective. And it's great to see how much thought's gone into it. I really look forward. There were so many questions, and the interesting questions, but a lot of questions that didn't get answered. So I think that there's tremendous opportunity for these working groups to really sort through what's been going on and what's known, and build again on it some more, and move forward in some pretty accelerated ways. I did want to note a couple of things. When we started talking about intersectional stigma, it was still a fairly new concept to me, and how far it's come now. But some of the interacting themes of the intersecting stigma that came through, at least in my simplistic view, are the intersection of structural and lived experiences and how those can really have an impact on each other. The intersection of community and academia. And I think that the HIV/AIDS research world has really propelled the importance of community involvement in whatever we do. And so that came through pretty clearly. The intersection of rigor and innovation. So we want to be innovative, but we also don't want to sacrifice rigor in our innovation. And I think that really came through pretty clearly today too. And finally, the intersection of stigma, discrimination, and resilience. So, I mean, resilience is a really interesting concept, and we have so little understanding of what constitutes resilience, and we're learning a lot about stigma and discrimination, and I think in integrating some understanding of resilience is really important, and maybe can be something to think about as we move forward in some of this research. So it's been a great afternoon. I'm really grateful to everyone. I learned a lot, and I look forward to hearing. I will join some of the discussions when I can, and I will definitely be there for the full readout. So thanks again, everyone, and have a great afternoon.
But don't hang up
yet. And I turn it back to you guys.
So thank you. I think that leaves Greg and I. And I just want to say on behalf of Greg and Amber, the workshop planning group, I would like certainly to thank everyone for participating today. Today's discussions and presentations has provided depth and breadth to the discussions and work that we will have ahead of us. Both co-chairs touched on the questions that were submitted. We weren't able to get to many of the great questions, but what we will do at the co-chair's behest is we will make those questions, all the questions submitted today, available to you within the workshop phase 2 session. I would also like to thank and acknowledge our co-chairs today and our welcoming speakers, as well as our moderators and presenters, for making it a truly productive and insightful day. People have been providing side comments, and they have almost uniformly been really complimentary about the value of today, except for that one. No, I'll leave that alone. And I would like to thank Kayla in particular for the pre-phase 1 preparations and for keeping us running well throughout the day. I'll turn this over to Greg to touch on next steps and to adjourn us for the day. Greg?
Great. Thank you so much. Thank you, Dr. Goodenow and Rausch. And really thank you, everyone, for hanging in there with us today and for, yet another full day of webinars after AIDS 2020. And I so very much appreciate the moderators and presenters and speakers today. But I very much appreciate your participation in the phase 2 virtual work groups. We have really top-notch facilitators. We have folks helping us out with note-taking. We have folks who've signed up to do the report out in September. And we have folks, volunteering to help lead some writing. So our work is not done. We have much more to do. And so tomorrow you will be receiving a calendar invite with the first work group for the first call. We did our best for the folks who, responded to the doodle poll to find a time that was, mutually convenient for all. We really beg your patience, and if you can't join the first call, we really hope you will try to join the second or third call. We will try to limit the number of calls so that we make your time efficient. There will be an unedited webinar link that will be available very soon, either by the end of this week or early next, so you can watch portions of the presentation. Like I said, we'll have really high-quality recordings available publicly sometime this summer. And then we'll make sure we have that you get access to the slides as you start the work group discussions. We will do our best to support these work groups and make them help them run as efficiently as possible. So again, just a huge thanks. I'm really quite thrilled, and I feel like we made it past phase 1, and now we welcome phases 2 and 3 to come. So with that, everybody have a really fantastic day. Be well and take good care.
We made it past phase 1 with joy and pleasure and edification.
That's right. So this concludes our day. Thank you so much. Take care.
Thank you, everyone. Bye-bye.